Okay. Um, all right, we are live. Okay, humble print. Go ahead.
All right. Good morning, everybody. I'd like to welcome each and every one of you to today's Zoom, Nigeria's response to COVID-19 and how to prepare for the next pandemic. This is brought to you today by Iroko Post Media Group. Thank you very much. Today's host, ladies and gentlemen, does not need any introduction, but I'll go ahead and just read a little bit about him. He's a Nigerian-American journalist and writer. He is an adjunct professor of Afro-diaspora literature and post-colonial African history at the School of Visual Arts in New York City.
Thank you very much. Today's host, ladies and gentlemen, does not need any introduction.
Can somebody mute their phones?
Go ahead and just read a little bit about him. He's a Nigerian-American journalist and writer. He's an adjunct professor of Afro-diaspora literature and post-colonial African history.
He's also the host of the satirical show Dr. Damages on Iroko Post TV Online, YouTube. He has also been featured in the New York Times, BBC, and The Guardian of London. His most recent books are This American Life Theft and The Secret Letters of President Donald J. Trump, age 72, 1/6. He's also the author of a book of essays, Children of a Retired God, a chapter of his memoir, Because I Am My Grandfather, which was a finalist in the 2010 John Gullion Literary Nonfiction Prize competition. Ladies and gentlemen, please, let's welcome the man himself, the one and only Rudolph Okonkwo, aka Dr. Njakịrị Damages.
Thank you so much. Thank you so much.
My grandfather, which was a finalist in the 2010 John Gullion Literary Nonfiction Prize competition. Ladies and gentlemen, please, let's welcome the man himself, the one and only Rudolph Okonkwo, aka Dr. Njakịrị Damages.
Thank you so much. Thank you so much. All right. I'm so sorry. I have no idea what's going on today. But I appreciate this opportunity. I want to thank everybody for joining us today. This is a very close, something very close to my heart, this conference that we're having today. I really appreciate the time that you all took to join us. And we want to talk about COVID in Nigeria, how we handled COVID, and how we are going to prepare for the next pandemic should that happen. I have a prepared remark, but we are so behind in our time, and we want to make sure that we go ahead and get the conversation started. I want to begin by asking the MC, who is Humble Prince. Thank you so much for that wonderful introduction. And I want to use that opportunity to say that can you introduce my co-host? We have two panels today. The first panel, we discuss COVID from the perspective of doctors who either they were the people who are policymakers or doctors who were in different profession in terms of we have people that will look at it from the role of researchers and the role of people who treat their patients. We also have patients who were COVID patients who will join us and tell us the story. We want to achieve something today. We want to see if we can learn, have a cross-continental conversation, learn from people who are here in America, patients who suffered from COVID here in America, also from doctors who treated patients in America, and also those in Nigeria. And also we have the media who will tell us the story of how they covered the pandemic. And from the NGO, we're also going to have NGO members who will tell us the role they play in such pandemic. The goal generally is that at the end of the day, we are going to learn something. We are going to come up with something that will help us to deal with the next pandemic. I'm sorry about the hitches we have at the beginning, but we are starting and it's going to be better. Thank you, Humble Prince, for that introduction. If you can just introduce my co-moderator for the first panel, we can start from there.
Yes, thank you very much, Rudolph. We'd like to introduce Dr. Ngozi Obinwane, MD. She's a clinical research professional in Dallas, Texas. Please welcome to today's Zoom. Let's give her a round of applause, ladies and gentlemen. Please. Thank you very much.
Hello, everyone. Thank you, Humble Prince.
Morning.
Thank you, Dr. Damages, for this wonderful opportunity. I actually reside in Dallas, Texas, as stated, and I'm an MD, graduated from University of Calgary, Nigeria, and currently here into clinical research, and currently working on acting on the Moderna vaccine, where the PPD and Thermo Fisher scientific collaboration. So I've had a little first-hand experience on the effects and the efficacy of the vaccines throughout the course of the research, and being able to monitor sites and also review the patients. And I must say that I'm glad to be here today. So I hope to contribute a little bit of what I've experienced to everyone's listening. Thank you, everyone.
All right, Doctor.
Sure. We're very honored to have you here. Thank you.
Yeah, thank you so much. Now, let me introduce our first speaker. Our first speaker is Dr. Sani Aliyu. He is a former national coordinator of the Presidential Task Force on COVID-19 and also former Director General of the National Agency for the Control of AIDS. Dr. Aliyu will speak on how Nigeria dealt with the COVID-19 pandemic. Dr. Aliyu, welcome to the show.
Thank you, Rudolph. Can you hear me clearly?
Yeah, we can hear you.
Yes, we can.
Okay, great. Well, thank you, Rudolph. Thank you, Humble Prince, for inviting me. I'm pleased to see that my colleague and successor, Dr. Mukhtar Mohammed, is online as well. I think it would be useful having him and hearing his perspective, because I left the PTF more than a year ago, back in April last year. So what I'll be saying will probably be mostly historical. But I thought over the next 10 minutes, I'll be talking about three things: where we are now in terms of the COVID response in Nigeria, how did we get here, and in my view, what we should be responding to in the long term. And just to make it clear, I'm no longer in Nigeria. I'm now back in Cambridge. I work as a consultant in microbiology and infection at Cambridge University Hospitals. So some of the things I might say might look like it's coming more from the sort of advanced country perspective rather than a developing country perspective. So where are we now? So far, looking at the website for the Nigeria COVID response, we've tested 5.4 million persons for COVID. We've had about 261,000 cases and about 3,000 deaths, unfortunately. I must say that this figure is a gross underestimate of what has been going on in Nigeria. In the first instance, the number of people testing for COVID has gone down significantly over the last 1 year, possibly because of generally from a public perspective, people feel that COVID is no longer an issue. The number of deaths as well is a gross underestimate. But having said that, one thing that is unique with the Nigeria COVID epidemic is the fact that the mortality rate in certain age groups is quite high. If you look at the case fatality rate for people between the ages of 51 to 60, it was about 6.5%. And in fact, if you're above the age of 60, you have a 1 in 7 chance of dying if you catch COVID. That's significantly more than what we see in other parts of the world. In terms of vaccination as well, about 25 million Nigerians have been fully vaccinated, which is only about 12% of the population. So we still have a very long way to go. So when we talk about how did we get here, you probably would remember that the Presidential Task Force was inaugurated in March 2020, and the membership was drawn predominantly from the President's cabinet. It was formed really as a platform for executive decision making, and at the time the PTF was formed, it was formulated very similar to the US approach. In fact, the US government announced its own presidential task force a few weeks before Nigeria did, and we looked at the way they had set their own PTF and decided to model our own PTF in a very similar manner with very high level executive function and a need for a coordinated multi-sectoral response that will ensure that we have a cohesive and effective public health approach, whereby all sectors will be involved and resources can be mobilized fairly quickly. We also had a comprehensive recovery plan post-pandemic, because we knew hopefully that will be around post-COVID. In terms of the coordinated nature of the response, I think the coordination side worked really well. But there were impacts of some of the decisions we took, which in hindsight, I think they were still the right decisions at the time, because nobody could predict how impacted the country will be when it comes to COVID. We could see what was happening then in other parts of the world. The economic impact was the one that I think we probably underestimated, because by the time we did a survey, there was a survey that we did with the National Bureau of Statistics in May 2020, just after we had opened up, which showed that over 2,000 households were interviewed. About 40% of these households, the heads of the households had lost their jobs, possibly because Nigeria is a very informal economy. 80% reported a decrease in their household income. 84% reported an increase in prices, and there was a real drop in terms of access to certain medical measures, such as outpatient attendance, HIV counseling and testing, and even childhood vaccination rates. These were all impacted by COVID. But from a more positive aspect, the multi-sectoral meetings that we had were really helpful when it came to telling people what was going on. For several weeks, we were on TV, on national TV, every day after our meetings, briefing the general public on what was happening, what the COVID numbers were, what the key issues were of the day, and what the decisions were in terms of relaxing. We also deployed a large number of rapid response teams. We made use of what was available in terms of diagnostics. We already had HIV labs across the country, which we mobilized for testing, including the use of TB facilities for tuberculosis for diagnosis of COVID. And subsequently, we encouraged the private sector to set up laboratories specifically for COVID testing, especially from the perspective of travel. We worked very closely with the state governments to activate 131 treatment centers. And at the time COVID came, Nigeria had only about 250 ICU beds. We were able to double that number over the year that we operated, as well as distribute over 200 ventilators and more than 4,000 oxygen delivery equipment. One thing that's not very clear to the public is the number of people that have been trained as a result of COVID. So for instance, over 20,000 healthcare workers in Nigeria were trained on infection prevention and control. What's that? That's more to do with how to handle patients and preventing transmission going from one patient to another, such as the importance of hand washing, the importance of isolating people that have infections, etc. And that benefit continues to be felt even after COVID. Because at the moment, we're still able to make use of those healthcare workers to apply the knowledge that they have. Risk communication was also a big thing. We trained over 62,000 persons on risk communication. We worked very effectively with the Federal Ministry of Information and Culture. We also worked with the some of the national agencies that had to do with mobilization, for instance, to mobilize over 800,000 community volunteers. Even the person in the village knew about COVID and knew that COVID was real. And we did try to, as much as possible, to address some of the negative press that was coming out in relation to this. But having said all this, what were the issues that we continue to have? And in my view, what do we need to really look at? Well, first of all, we need to learn from the engagement that we had with the private sector. The Coalition Against Coronavirus Disease was a private sector coalition, which was brought by the CBN governor together with some of the bank executives. It mobilized 40 billion naira, which was the initial target, and we were able to achieve 96% of that target. And most of the funds that came to COVID, government did not have access to this at all. But we were able to tell COVID, this is what is needed. Lagos State require more communication facilities. Kano requires more in terms of ambulances, etc. There's a need to support the provision of amenities, for instance. we were able to tell the private sector what the public required or what the government required to fight COVID. It was a very unique way of addressing a pandemic, and it's something that we really need to learn from as we move forward, especially in the event of a future pandemic. We also had very effective relationship with the multilaterals. The UN set up a UN basket where all the UN agencies contributed to, including other partners such as Gates Foundation, etc. And they had an annual budget of about 70 million US dollars, of which they distributed about 56 million US dollars. The key contributors were the European Union. But again, these funds did not find their way into government at all. All we did was we worked very closely with them, identified where the needs were, and they were able to put in place implementation arrangements. Testing was also a very important aspect that we need to also realize is important when it comes to pandemic response. We were able to mobilize a lot of testing centers, distribute a lot of testing materials, even though I do agree that the number of tests we're still doing in the country is grossly inadequate. But at some point, we were able to expand to more than 400,000 PCR test kits. And I'm pleased to see that NCDC at the moment are now making better use of rapid test kits, which is what we use in the UK now. We also supported very closely the aviation authorities in terms of travel arrangements. But where do we go from here? Now, my view when it comes to COVID is you cannot get on top of COVID without sorting out your vaccination arrangements. You really can't. And this is where people like Rudolph and my good colleagues online really need to take the fight. We need to get our citizens vaccinated. It's the only way we can get on top of this. Yes, there are variants that are emerging, some of which have the ability to overwhelm the system, but the presentation of illness in vaccinated people is very different. Here in our hospital in Cambridge, we still have people coming in with COVID. Most of them are incidental, but we don't have a single case in the ICU, in the intensive care. People are having a cold, but they are not very sick. And that's what we need to do, because we need to get our economies working again. Closing down is no longer an option. Neither is it an option to isolate people, etc. The approach should be to make COVID a mild illness, and that can only be achieved through vaccination. So I will stop here, but thank you very much for inviting me, and I'm sure there will be further questions online later on. Thank you very much.
All right, thank you so much, Dr. Aliyu. We appreciate your contribution. We will skip survivor story. We have stories of people who survived the COVID illness, and we will go straight to our next presenter. Dr. Obimane, please introduce our next presenter.
Hello, everyone. Hello again. I am introducing our next presenter will be Dr. Mukhtar Mohammed. Dr. Mukhtar is a National Incident Manager and a member of the Presidential Steering Committee on COVID-19. And he will speak on where Nigeria is currently in its preparation for another pandemic. Welcome, Dr. Mohammed. You have the floor now. Dr. Mohammed, can you unmute yourself?
It's muted and we can't hear him.
Okay, good afternoon, good morning, everyone. Thank you, Ngozi, for the generous introduction. Dr. Rudolph, thank you for the invitation. Colleagues, I'm glad to again meet with my predecessor, the National Coordinator, Dr. Sani, who has put immense effort and sacrifice in the setting of the Presidential Task Force and all the achievement that the committee has made in the last 2 years. So I think he has laid very much the ground about where it's been, how it started, what efforts have been made. And that really makes it easy for me to discuss about where we are now and what we need to do to prevent further pandemics in the country. COVID-19 has actually galvanized the international community, all countries, to come together to realize that we have to work together to fight the pandemic. Having COVID-19 in one place does not make another place safe. So we really have to put efforts to make sure that there is this international collaboration. So Nigeria has keyed into many of these efforts that are going on regionally in West Africa, in the African continent, and also globally. And generally, there are discussions between the general similar agencies about strategies, next steps, and what needs to happen in terms of epidemic preparedness, in terms of getting the vaccines to the arms, in terms of logistics, using testing technologies, and so on and so forth. That's on the global scale. For us in Nigeria here, we are concentrating on doing the little things that will reduce the impact or prepare us better when we have another epidemic or the next pandemic. We do not clearly know what form that pandemic is going to take. And therefore, you cannot say that you are 100% ready and you have everything in place. But at least based on the experience we had from Ebola, COVID, Lassa fever that have been going on, and now we have monkeypox, at least we have a direction about what needs to happen. I think Dr. Sani has spoken very well about the capacity building. That has been intensified. I'm proud to say now that many epidemiologists have been trained in all the states of the Federation, not only clinical epidemiologists, but also other cadres of health workers have been trained in various aspects and the roles they can play in terms of epidemic preparedness and control. In terms of clinical care, I think the PTF really saw the seed where we saw a lot of activities going on in terms of building intensive care units, supporting capacity for isolation, and also even putting dedicated funds. The PTF, or the Presidential Steering Committee, has dedicated some funds that were meant for all the teaching hospitals in all the state federation, for increasing their capacity in terms of intensive care, as well as building isolation facility. We've also provided funds, in terms of, like Sani mentioned, building the molecular laboratories, and also looking at the epicenters. Lagos and Abuja have been prioritized. And also the procurement and distribution of PPEs, that will make people safe. The NCDC, the enabling law that has established the NCDC has also been strengthened because we realized that there were some gaps very early on with COVID pandemic regarding quarantine and the powers that the agency would have. So all these issues have now been sorted out in collaboration with the National Assembly, such that if there is an epidemic or there is cause to take action, the NCDC or the public health officials will now have unhindered access, to the property and also be able to interject and also, take the necessary actions that are required. In terms of the public health approach, the Nigeria, what we call the Field Epidemiology and Laboratory Training Program has been intensified. Now we have over 1,000 graduates and people that are still going on in training. This is specialized training for epidemic intelligence. It is targeted at looking at these kind of unusual epidemics or pandemics that have the tendency to propagate and also have very high case fatality. The case has now been, the program has now been assimilated by the Nigeria Centers for Disease Control. Initially, it was supported by USCDC, but now we have internalized it. And the Nigeria Centers for Disease Control has taken the responsibility to continue to train and churn out, these capacities across the country. In addition to this, we have realized even before the COVID-19 pandemic that one of the weak points of the Nigeria health system was data collection. So a lot of resources have now been put in terms of collecting data. We have improvement in what we call the IDSR, which is the surveillance system of reporting diseases from the wards, from the villages to the local government, to the state, and also to the center. We have strengthened the coordination between the epidemiologists so that all the states and the NCDC and Federal Ministry of Health meet periodically, at least twice in a month, to discuss current issues. Like currently they discuss issues of monkeypox, the number of cases that are going on, what actions have been taken, and what are the likely areas that may be affected. So I think let me just also pause here because I'm sure there will be maybe some additional questions. But the bottom line is that yes, we won't say we are perfectly ready, but certainly we are intensifying and strengthening on the efforts that have been done before, and we are collaborating both regionally at the continent level and also internationally, because fighting pandemics cannot be done just in one place. We really have to work together to set up the systems and the methods to fight these pandemics. Thank you.
Thank you, Dr. Mohammed, for this awesome delivery. We'll now want to bring on Professor Wosu. I am very sure that many of us will have questions for you, Dr. Mohammed, and we'll get to that very soon. So it's my honor to introduce the next speaker, and he is Professor Benjamin Wosu. He is a chief endocrinologist at the Cohen Children's Medical Center, New York, and a professor of pediatrics at the Zucker School of Medicine. Professor Wosu will speak on the role of the teaching hospitals in preparing a nation for medical emergencies. Professor Wosu, it's now your turn. Welcome.
Thank you, everyone. Thank you for the introduction. Thank you, the host, for inviting me and the audience. Before I start, I want to say that I will take the position of the Nigerian youth. I'm not a government official. I'm not being paid for my participation in this session. So here is how I will start. We have to set the Nigerian COVID pandemic in perspective. Compared to US, Europe, Brazil, India, COVID-19 did not really touch Nigeria. Okay, so that's the context. And number two, is Nigeria ready for the next pandemic? I can absolutely say Nigeria is not ready for the next pandemic. And here are the reasons. One, Nigeria does not have the funds to actually address a pandemic. Nigeria is going to go bankrupt before the end of this year, for those who wish to know. There is no structural alignment of the healthcare facilities in Nigeria. The teaching hospitals are supposed to be the flagship centers where people will go for last resort. I was in Nigeria in 2021, and people were dying in teaching hospitals just because they have manifested the symptoms that might be suggestive of COVID-19, not that they have been confirmed as cases. So once they show symptoms, the healthcare providers will abscond. Now, there is no national will to take on a pandemic in Nigeria as far as I'm concerned. Like I said, I was there in 2021 to renew my passport, and people were fighting to get in line, at the center, nobody was wearing masks and so on. So I was so afraid that I could even contract this person. Then you think, I gave a lecture on Nigeria's Millennial Developmental Goals in 2021, and whether Nigeria met the stipulations or not. And Nigeria did not. I mean, the only thing Nigeria had to show was the NCDC, okay? So we give them a high mark for that. But the integration of rural health provision and then secondary health care services with the tertiary care services, which the teaching hospitals are set up to do, is completely lacking. You cannot refer a patient from a primary care center in Nigeria to a teaching hospital easily, okay? And when you get into the teaching hospitals, there's a huge issue of conflict of interest. Most of the consultants have parallel medical clinics where patients are being diverted to. Okay, it is the federal government has looked away from this issue for too long. People die because they don't have the money to pay for services at the teaching hospitals that are receiving money from the federal government. You have ministers and other governmental officials who never visit teaching hospitals in Nigeria. You have federal government officials who have doctors overseas. We know this because we are here, okay? Not a joke, we can give names. And so they don't care about the hospitals in Nigeria. Because if they use the hospitals in Nigeria, they will see that they are derelict. Okay. People talked of, oh, we are going to build capacity. Well, what does it mean to build capacity? Why didn't you build capacity as part of your millennial developmental goal? People talk about we're going to take little steps. Why are you taking little steps? Nigeria is the giant of Africa. Can't you take bold steps? People talk about data collection, but how many publications have come out of Nigeria on COVID-19? Isn't it interesting that COVID-19, for whatever reason, blew through Africa, you know? Except for South Africa, COVID-19 basically blew through most of the African regions. And so isn't it important to do a study to find out what is unique about Africans regarding COVID-19? I hope there are papers, so I hope I'm wrong here. Now, were the COVID-19 test kits free to the people? I know I had to pay thousands to do my test in Nigeria. So I want to know whether the villagers were getting these tests free of charge. Now, there were 131 treatment centers in Nigeria. Can we please tell us what states these centers were in? And were they concentrated in Lagos and Abuja only? And that takes me to the next comment. Why prioritize Lagos and Abuja? Is it because the rich people live there? What of the villages? If you cannot strengthen primary care, then you cannot go far. So let me conclude by saying that Nigeria is not ready for any meaningful pandemic effort. And I'll take questions later on down the road. Thank you.
All right, thank you so much, Professor Nwosu, for that presentation. We are going to have one more panelist talk, and then we take questions from the audience and then continue the conversation. So it's my honor to introduce Dr. John Ndibe. Dr. Ndibe is a retired director of the Medical Services, Anambra State. He's currently a consultant for USAID-funded KNCV Global Vax project in Anambra State. He will speak on how states can coordinate with the federal government and the role of ADA. Dr. Ndibe, welcome to the show.
Yeah, thank you, Rudolph and Uzo for the invitation. And also, I greet all the panelists and our listeners. I want to start by saying that in Nigeria, basically, Nigeria has some structural problems in terms of its, in fact, across all its health intervention. Nigeria is a situation where we have a kind of misfit between where the problem is and where the resources are. It's an issue of an imparted where resources are more at the federal level government problem of the health sector are. And so you find a situation where even though it's the PSCs, the general hospitals that we expect to have most of the patients or solve most of the health problem, you find that that is the level where resources is least. And then at the federal level where they should be doing more of policy and guidance, you find a lot of resources there. And so that's a situation of where the needs are, the base of the needs is down, but the base of the resources is up. And this is a kind of misfit. This makes it imperative that most of the states, to a large extent, depend on the federal government when it comes to health issues, especially in pandemics like COVID that require a lot of resources to control. Even in terms of human resources, you find that the most knowledgeable people are at the federal level. So whenever there is a problem or a health issue or a pandemic in the state or the local government, you find that people need to come from Abuja to come and assist to address these issues. So it's not different with the COVID. So when COVID came, actually, a lot of what states did had to depend on assistance and directive from the federal government. And that is the relationship that has always existed in most of the health interventions that we have. Now, when COVID came, actually, the intervention actually started at the federal level. But I must give it to the fact that the Presidential Task Force actually helped to mobilize a lot of resources, which ordinarily would not have been available to the states. And they assisted the states in establishing some testing centers, providing PPEs, and even some drugs that were needed when the pandemic soon, because that structure, that resources are where the problems are still exist. And trainings that the lower centers, lower levels have are still things that are supported mainly by the federal government. So that also happened in the COVID pandemic, and I think it continues to happen now. However, I must admit that a lot of progress was done. There was a lot of support actually from the federal government, the Presidential Task Force, the NCDC, the WHO, and some other partners who actually supported the state to be able to establish some structures. The emergency operation centers in most states were strengthened. Rapid response teams in the states were also established and strengthened by resources from the higher centers and from some of these NGOs and implementing partners. in Anambra State specifically, I know some centers were actually taken up by private organizations. For instance, at Umueri General Hospital, Access Bank, when I was just leaving the service, actually built and refurbished the center and equipped it with a lot of COVID materials required to respirators, beds, and all that, basically all that was there. And it was quite massive. And a few other centers also benefit from that. So basically, I would say that going forward and in the foreseeable future, states will continue to depend on federal government and the private sector. And if that be the case, it means that we need to actually have a plan that is well prepared to be able to harness those resources whenever epidemics happen. Fortunately, every state now has trained disease surveillance and notification officers, both at the local government and at state level. And these groups this cadre of people are people who are supposed to pick up any unusual illness or collection of illnesses that occur and be able to notify to the state and then to the federal, and because that is where the resources are. Even I don't think there is any state, well, maybe apart from maybe, I don't know, Lagos may have, but in the state, I don't think there is any laboratory where any new disease entity can be properly investigated. So basically, is to collect samples and transmit to these specialized labs where maybe decisions can be taken. Going forward, a lot of, and the stage where we are now, I think the emphasis is on vaccination to address the COVID pandemic. And even at that, you still find that basically the state depends on the federal level and donors. Claim donors like the KNCB, which is now doing a 1 year, you said, funded global vax project to help, accelerate vaccine uptake in the states. And so even to train staff, the state still depends on these entities, donors, federal government, to be able to conduct this training, WHO and UNICEF and all that. So it's really a problem that or a challenge, if you may call it that, needs to be addressed for the health sector to become more vibrant at the lower levels. I think Nigeria has to actually address frontally its structural distribution of where resources are, to empower lower level governments, state and local governments, to be able to actually take some initiative, because the way it is now is like, for me, it's like a servant-master relationship. You're always throwing cap in hand to the federal government, to donors, to NGOs for this and that whenever the state has issues. And we are trying to say, and while we were there, it was always a problem. To get resources to do even minimal things is almost impossible, except that assistance comes from health. So it's a problem that is cross-cutting across all health issues, not just the COVID pandemic. And I think we need to look at that as a major challenge that needs to be addressed. Now, in terms of uptake now, because even when the KSTV supporting this uptake, we find that there are still a lot of gaps in terms of mobilization, which is an area you think the state would have been able to at least come up with, to mobilize people to come actually assess these vaccines and these other. But even the mobilization, you still find that they are looking for partners who will support mobilization, who will support the training of the health workers to be able to give vaccines and all that and record appropriately. So I think this is the major angle I'm looking at. I have tried to look at these problems, and it's really a long way to go before we can start, except really we restructure such a way that these lower entities will also become vibrant and strong financially. I think I want to stop here. If there are questions, then maybe we can expatiate on some issues. Thank you very much.
Okay, thank you, Dr. John Debe, for this great presentation. And right now we'll go into the question and answer segment. So anyone that has a question, please bring it forward for the panelists to respond to. Thank you.
I think there is a question on the chart from Professor Ndibe about demographics or the risk factors for COVID comorbidity in Nigeria. And this is apt to my previous comments, because I was asking, where are the studies from Nigeria on the factors that underpin COVID-19 severity? Did it affect the elderly more or the children more? Workers, obese people, or otherwise? Is there no person or institution that is capable of taking up this deeper dive into COVID-19? All we talk about is how we built 2 centers here and 3 centers there, how we trained 5 people here and 20 people there. But there is no granularity, there is no depth. Even at my former institution where I left before, while COVID was raging, we actually wrote about COVID and children with type 1 diabetes, whether there was increased effect during that lockdown. So I agree with his question, and I leave it to the government officials on the panel to please educate us on what were the determinants of COVID severity in Nigeria.
So if I may be allowed to come on board, Chairman. So Professor Nwosu, thank you for your statements. First of all, I'll start with a statement that you started off with earlier on, where you said COVID did not touch our country. I hope that doesn't mean that the 3,000 plus people, which is an underestimate of the number of people who died from COVID in Nigeria, were not considered as significant. We know the issue with COVID, there's a significant amount of underestimation of the disease burden in the country, partly because of testing. When it comes to the issue of testing, travel testing has never been free. As far as I'm aware, virtually most countries in the world, you charge for testing. But when it comes to actual COVID testing for the purpose of epidemiology and disease, it's free in Nigeria. Anybody, any center, any lab, public health laboratory or lab that is owned by the state government charging for COVID testing, it's wrong. It means that they're just taking money off people, because those COVID test kits were provided for free to the centers. They were not bought for the purpose of selling. However, for travel testing, I have no problem with travel testing being charged, because travel testing in itself is a private endeavor that people should be charged for. And in any case, there aren't enough resources for government to be paying for free COVID testing for travelers. But having said that, I'm no longer a government official anyway. Going back to your issue of publications, myself and colleagues have published at least 5 papers on our experience with COVID-19 in the country. If you check, you will find either myself or Ibrahim Abubakar, who is currently the dean, a dean of the Faculty of Population Health Sciences in University College London, or a host of other colleagues, including a paper that we wrote where we included some of the members of the Presidential Task Force itself. Our experience is well documented. Even at the moment, we are in the process of resubmitting another paper to be published in a major journal on the differences between the COVID response in Nigeria versus the West versus other parts of the world, such as Southeast Asia. So yes, we know that we have problems in our country. There's no doubt that we have health issues. There's no doubt that the health system is not working. But the advent of the Presidential Task Force, followed by the Presidential Steering Committee, has been a very positive thing for the country. I can stand on my 2 feet and say that the system has benefited from the structured and coordinated way we run the COVID response. Yes, we could have done things differently. And I do agree, if people say maybe the lockdown, for instance, with retrospect, the lockdown had an adverse impact on our economy. It could have been done in a different way, yes, but we were trying to avoid people dying unnecessarily of COVID. And in any case, at that time, nobody really knew what the true impact would be. I have colleagues in the National Institute for Medical Research, NIMA, that at the moment we are funding through a major research program with the University of Cambridge, where we are looking into not only the epidemiology of COVID in Nigeria, but drilling down to even the variants that are emerging. Where are they emerging from? What are their susceptibilities? What is the issue with when it comes to the availability of other COVID medications that are currently being used outside the country and their impact? So in summary, what I'm trying to say is, if we make a statement, we really need to look. If we are not sure, this is the purpose of the web, at least to inform people, to let people know what is going on. And where we have weaknesses in the system, such as the current low vaccination coverage, we find a way to deal with it. Thank you.
I may also add, thank you very much, Dr. Sani, to that point. Certainly the purpose of making publication is to use the data. I am personally aware of over 15 papers that have been written, largely guided by the US Centers for Disease Control and the Nigeria Centers for Disease Control through the Africa Epidemiology Network. These papers have been published and they have been presented in international conferences. But for us as a country, the important thing is using the data. Each of the major hospitals that have isolation facilities constantly review their data, and it is based on that data that decisions inform the actions that are taken by Federal Ministry of Health. Every week, I'm aware that there is a review of the case management data by Federal Ministry of Health, presented by all the case managers from all of the tertiary institutions in the country. And this data characterizes who are the people at risk, who are the people who died, who are the people who recovered, how long did it take to recover. All these variables and indices, are things that are followed. And outside that, our academic institutions also are requesting for data to work on it. We have a whole research group that is multidisciplinary, centered within the Ministry of Health, that facilitates research. There are a few little, operational research that are going on regarding attitude of people, to COVID care, the quality of care that they have received, and also the, some of the clinical variables observation. In terms of that. But having said this, let me go back to the issue of why Lagos and Abuja. COVID came, and in epidemic preparedness, knows there is somewhere that is a focus of infection. COVID did not start in Nigeria, and it was largely, our epidemic was driven by international travel. And as we know, Lagos, almost 70% of all the passengers that come to Nigeria go to Lagos. Ebola came to Lagos, and COVID, when it came, it also went to Lagos. And then next after Lagos is Abuja and Kano. And that is why, because these are the gateway, these are the areas where the, diseases of international concern kind of travel through. And that's why we strengthen our surveillance system in these areas. And that is why the focus is really there. And the numbers don't lie. The numbers of Lagos are not comparable to the numbers in Yobe State or in Gombe State. So there are reasons, for all of this. Thank you.
Thank you for the response. I think Dr. Ndibe has a question. Please go ahead, Dr. Ndibe.
Professor Ndibe, no, it's Professor Ndibe. Okay, Ndibe.
I'm sorry. Professor Ndibe, please go ahead, please.
Hello? Is it me?
Yeah, Professor Ndibe, go ahead, please.
Okay, good. Let me start my video because I want my face to be seen as I speak. Can you all hear me?
Yes.
Okay, so I'd like to respond to part of the presentation. I think that Dr. Sani Aliyu was just speaking about vaccine uptake. And that's something that I have profound issues with because in America and elsewhere, people are now being told at some demographic groups to take, maybe the second booster or the third booster and so on. Nigeria doesn't have the resources to give everybody even one vaccine, one shot. And this is the first time in history, perhaps, where we're administering jabs that do not stop transmission and jabs that are in a lot of ways experimental. This is the first time that the mRNA vaccines have been used on this global scale. There are questions about there being leaky vaccines, which are not effective at stopping. So the goalpost has moved. Initially they said, you take it and you will not have COVID. And then you're told that you take it and you will not have severity of case and so on. So we are now at even the sub-Omicron variants, the sort of more transmissibility, but less lethality. So I'm wondering if vaccination is a proper policy in Nigeria when a lot of people, even in the West, are questioning whether these vaccines were the proper response to a pandemic, which they have been unable to stop. And you look at the world, most of the cases are rising in countries where vaccination has been the highest rates and so on. So I want to question this idea that an uptake in vaccination is something good for Nigeria. And the other question is that Dr. Babalola from Nigeria has been part of a study which shows efficacy of ivermectin, which is a medication that is widely available. It's off license, and so it can be produced by any pharmaceutical company. I know that there has been some international effort to sort of suppress ivermectin, but you look at those who have had COVID, and more of them are swearing by the efficacy of ivermectin. And where a Nigerian Dr. Babalola has been part of a study that shows its efficacy. I'm wondering if we shouldn't delink from this consensus by the West and perhaps begin to think about what works for us. So I'm going to shut up and listen to your responses. Thank you.
Thank you. If I may come into the issue of vaccination. So there are two purposes at the moment when it comes to COVID vaccine: to reduce the severity of illness and to also reduce the risk of the number of cases overwhelming a health system. The COVID vaccines achieve this. Yes, COVID vaccines will not stop transmission. Yes, COVID-19 will not stop you from having the vaccine, especially beyond 6 months, will not stop you from getting COVID again. But what it will do is that it will stop you from going into intensive care. It will stop you from requiring oxygen. It will stop you from taking over beds that should be used by other patients with malaria and other health conditions. And that's where we are at the moment. I'm part of a group that's currently funding major vaccine initiatives, which are now looking at wholesale vaccines where the vaccine itself that will be produced will not be dependent on variants. But I do agree with you that whatever vaccine that comes in, the likelihood is you will need to have more than one dose in a year. And I think the priority at the moment for Nigeria is to make sure as many people are vaccinated as possible but more importantly, those that are vulnerable to developing severe illnesses. Because if you have, for instance, if you are immunosuppressed, if you've had a transplant, if you have a badly controlled diabetes, if you have cardiovascular disease and you catch COVID and you do not have the vaccine, it doesn't matter whether it's a Delta variant or the Omicron variant, you're very likely to go onto a intensive care. The issue of ivermectin, I'm afraid, has already been resolved. There was a major multi-sector international study that was released a few months ago, and the evidence was very clear. I'm afraid ivermectin does not work. Thank you.
Okay, thank you so much, Professor Liu. I will go ahead and add on to that. From my background in clinical research on vaccines, yes, the vaccines are not a curative, is not a curative option. Rather, it's actually helping with those to keep us actually going into the severe reactive stage, and also helping those with comorbidities, keep them actually out of the ICU, as he stated. And there is efficacy. I know that because of when the EUA, when the vaccines were approved for emergency use, it was the Delta variant that was being dealt with. Now we have the Omicron variant, and we're still having more of the subvariants. So it's still actively ongoing, to cover all the variants that are coming up. But the truth is that those that receive the vaccine, from the data available now, there's less severity, although it comes in. So you see more of people with the flu-like symptoms, the cough, and it resolves. Other than we were having more of the SAEs, people dying as against what is obtainable now. So yes, and that is what it is here in the US. But when we talk about the vaccines in Nigeria, my question for the government officials is, how are logistics for what we already have? How are we sure of the stability and the viability of what the people are receiving? And for Dr. Mukhtar, I had a question: were those epidemiologists and the clinicians trained? What is the spread against the rural and the urban areas? And knowing that a lot of clinicians and epidemiologists, they really do not. Everybody would prefer to be in the city, and that we know, than going to the rural areas. So how are we getting in touch with those at the rural areas? Because yes, the Lagos and Abuja could be the epicenter, but we know that there's a lot of movement, and the way cities are structured, we can have a lot going on at the bottom, that we are actually taking note of. So yeah, we still have to talk. That's where we're coming with the human resources. So let me just leave it there.
Okay, thank you so much, Dr. Obiwan. Let me, because we have to be concerned about time, we have another panel that so what we're going to do now is we are going to take the question from Informa Okafor and then get a summary from Dr. Gladstone on the comment section, and then let them answer it, including including getting Professor Nwosu to respond to the comment on him. Then we go to the second panel. After the second panel, we'll have another question and answer. So, Ifeoma, you can ask your question.
Thank you. Good day, ladies and gentlemen. Ogo, thank you for putting this up. I am currently resident in the States, and I'm a government employee. I work within vital records, health statistics, and during the beginning of the COVID-19, there was, yes, a task force set up, but also what the state government did was to pull people from different departments to be part of that team, not necessarily with a medical background, but to answer questions, take phone calls, enter data into the system. And then for physicians and attorneys to review some of the emails that we end up sending out in response to those citizens or businesses or paracetamol, like you guys call it in Nigeria. Do we have any such thing in Nigeria? I know that I personally have, during the process and during all this, I was sending a lot of data to the key people in the presidency. I was sending it to them, and I could see certain things that were being used, but it's so they understand that there is a process. And let it not just be that typical, oh, it's Nigeria for you. You guys tried, but Ogo, you know, I lost 2 brothers, my eldest brother and my kid brother, to COVID. So it's not an easy thing. And I have suffered it along with my kids. And with the vaccines, and despite the boosters, when you get it, it's not easy. I'm still dealing with it right now. What are you telling the Nigerian community? Thank you.
Okay, thank you, Foma. Thank you so much for that question.
It was really emotional.
I'm seeing more people raising their hands. What we're going to do now, just so that we can, we'll give our panelists opportunity to respond. And then remember there will be another question and answer section after the next part. So that we can get to that. Let me call on Dr. Liu, if you're still there. We'll start with you, then Mukhtar, and then Professor Nwosu. And then Dr. Ndibe. Anybody?
I am sorry to hear about the experience of the last speaker when it comes to COVID. Certainly, COVID is not completely resolved. It's still very much around. But as I said earlier, the goal of vaccination is really to reduce the severity of the illness and to stop those that have other comorbidities from filling our intensive care units and possibly dying from the disease condition. There's still a lot of research going on in terms of coming up with much better vaccines that would have greater efficacy against a range of variants. But at the moment, that work is still in the sort of basic science stage. But I'll still keep on saying that in Africa, and especially in Nigeria, we'll be doing ourselves a disservice if we say that we are going down the route of not taking vaccination. I really hope that's not going to happen, because inevitably it will affect our health system. We have just seen another wave of COVID that's come and gone. Nigeria has been lucky partly because of the nature of the demography. The fact that we have a significant youth board. COVID, even for those that are not vaccinated but are relatively young, is very likely to be mild. But that does not mean that we won't have people dying from the disease. In terms of research, as I said, I'm not a government official, but I know a lot of resources are going into research to do with COVID, both at NIMA and some of our universities and teaching hospitals. That research is feeding into the current data that is coming through with regards to the efficacy of treatments. But whatever treatment we support in Nigeria, it's either a patient goes on a drug based on a clinical trial if that drug is not authorized for use, or we use drugs that have already got a very strong evidence base. Modern medicine is not the same as traditional medicine. I'm afraid it's not like going to your local babalawo. So if I'm giving you paracetamol as a physician, I need to be very certain that paracetamol will work. If I think it will work, then I will need to put you through a clinical trial where it will be measured and the efficacy will come from. So I'll stop here, but I'm sure Dr. Mukhtar will have responses with regards to some of the issues, especially the demand for vaccination and the logistics associated with vaccines. But working with the Africa Union Commission, we know that Africa is doing itself a great disservice if we continue to say that we will not take these vaccines, because the world will just turn back and say, well, there's no demand for the vaccines and we will use it elsewhere. Thank you.
Okay, so let me just quickly add that there are a lot of ongoing efforts to make sure that we increase the vaccination coverage. And we have seen the data on state-by-state basis, on the uptake. But still, it has not reached the level that we'll say we are comfortable. And this is not surprising because we know the attitude of Nigerians, particularly when they see that we have removed all the restrictions regarding COVID, when they see that people are not falling ill, when they see that people are not dying in the hospitals, and people, generally are lethargic about, coming out to take the vaccines. We also have, the booster program. I think Professor also asked about it. The booster doses are available. People are taking, their third booster and even additional ones, because we know, based on evidence now, that the vaccines wanes out. Getting into the rural communities, really, that is a challenge. Even though we have the Johnson & Johnson, which doesn't require much of the cold storage chain, but we have seen the efforts made by specific, leadership of states, where they mandated, the local governments to deliver on the vaccine coverage. What we do from the center at the national level is we insist that anyone who is traveling out of Nigeria must show evidence of vaccination. And this has paid a lot, because during the last Hajj program, all the pilgrims that left Nigeria, is about 40,000, had to be vaccinated. And when you are coming into Nigeria, you also need to show the evidence that you have received your vaccination. If you don't, then you will be required to test multiple times, in accordance with our protocol. So this is a kind of, a disincentive that we've created, so that people will not be encouraged to take the vaccine. As you are aware, it is not mandatory. I'm not sure any country has made it mandatory yet. But it's about the public knowledge and public awareness to make sure that people take up that. There was a question about the training and capacity building, about the spread. Certainly, the epidemic preparedness is an ongoing thing. Long before COVID, Nigeria we started our field epidemiology and training program in 2008. And we've been training, people, initially medical doctors, epidemiologists, then veterinary doctors, because there is the link between the animal disease and human. And then we're also training laboratory scientists on it. These are the training that leads to, award of a master's degree program. But underneath that also, we've had several mid-level and low-level training, which is targeted at local government, particularly the IDSR officers, the ones we call the surveillance officers in the states, and also in the local governments. So now all the local governments have dedicated surveillance focal persons, and these people have been trained in terms of reporting of the disease. They have an electronic means of, if they see a patient, if they see a cholera outbreak, they will be able to recognize, and they should be able to report to the state, and the state will report to the center. If there's a Lassa fever outbreak, they should be able to do that. And then there will be the response angle that will be coordinated between the state and the federal government. So these are ongoing efforts. We are not still satisfied with the level of training. As you know, it's a continuous effort. I think someone mentioned about the dysfunctional nature of the health system, but we are working within what is available now. We know that the health force is concentrated in the teaching hospitals for obvious reasons, because they are paid by federal government. The pay is better. If you're a consultant, what you earn in the federal teaching hospital is twice or more than what you earn if you're working, in a state hospital. There is generally disincentive for people to work in general hospitals, or for other health workers to go to primary healthcare centers. These are the areas that we need to strengthen through our basic healthcare provision fund, which we just started implementing, and also the universal health coverage, so that we make deliberate efforts to incentivize healthcare professionals to participate and work in lower health hospitals. Thank you.
Professor Mosso, please, if you want.
Thank you again for allowing me to speak. Again, my vantage point is that of the Nigerian youth and the Nigerian the poor people, Let me put it that way. The people with no voices. So my question is this, again, when we talked about research, I heard there were some papers coming out of Nigeria. I'm happy to hear that. I also want to see if these papers can be shared with the audience or at least sent to some of us. I want to see whether these papers are comparative epidemiological research, because I think they're comparing how Nigeria fought COVID compared to how it was done in the West. But why are we not looking at the real thing, the molecular research of how COVID impacted Nigerians? Two, even the vaccine that are being shipped to Nigeria, has there been any study looking at their immunogenicity? Okay, and then how long does it last? Are we just taking data from Europe and America and then basically using that as the Nigerian experience? Now, there were a lot of funds. We always say, oh, Nigeria doesn't have money. There were a lot of funds raised at the beginning of this pandemic by some Nigerians who donated billions of naira. What happened to that money? Okay. We talk about capacity building. Here in the US, at least I remember in my hospital, what they did was redeployment. One, when they were overwhelmed in the ICU and the wards, they went to a stadium and opened up clinics there. And then even those of us who had no training in internal medicine, who were asked to either volunteer as internists or laboratory technicians or whatever, just to make sure that things are moving. So you don't say, I'm building capacity every day, okay? We knew back, does anyone remember Health for All by year 2000 or I don't remember when Ransom Kuti was the health minister. Health for All by year 2000 or something. I think I'm getting the date wrong, but we're supposed to be healthy in Nigeria many decades ago. Why are we still building capacity? Okay. So, and then finally, the comment by Dr. Aliyu that when I said COVID blew past Africa, I wasn't making light of the 3,000 deaths that were recorded. However, if you look at the 3,000 deaths, can we please have data proving that they were actually due to COVID? That's one. I'm not saying they are not due to COVID, but this is where data collection is key. And then, of all the other deaths in Nigeria, do we have evidence that most of them were not due to COVID? Again, this is importance of data collection. So we may have underestimated what happened in Nigeria. Maybe 100,000 people died, but we don't know. So data collection is not something you do only in Lagos and Abuja. You have to set up nationwide data collection, like one of the speakers who lost relatives to COVID, sorry to hear that, said. These centers will have to feed data to the federal government. The over-centralization of healthcare in Nigeria is not working. There has to be regional decentralization. Thank you.
All right. Dr. Ndibe, do you have a comment or you want to contribute to this? Is this?
I can't hear you.
Oh, I was saying, do you have any comments?
Hello?
Do you have any comments?
No, the voice is still not. I have a voice issue here.
Okay. All right. Let me.
Better now.
Okay. So I was wondering if you have any comments.
It's gone down again.
Okay. All right. So what I want to do now is I want to do a little bit of what Dr. Gladson comment section, and not all of it. And then if there is final words from Dr. Dr. Gladson, wrote, this is just a summary. He was wondering, why did we insist on lockdown for as long as we did, even though that it was obvious that the elderly are the most at risk? And our population, if you look at the pyramid of our population, that is only 2.3% of Nigeria's population, that is over 65%. He has another question about how we have practiced safe distancing, considering that 10 people live in one room. And I know when I called him about this conference, he was one of those people I invited personally, and I wanted him to come. He mentioned the issue of not knowing how many people are born in Nigeria and how people die every day. So what are we doing to deal with it? So I'll give the last minute to our panelists. Anybody to weigh in on this, and then we'll go to the next thing.
So maybe I can answer the issue of why did we lock down for as long as we could, as we did, really. So I remember at the time that we locked down, everybody, people didn't really know what COVID was all about. People really didn't know what COVID was all about. People were frightened and afraid. Nigeria was one of the last countries among the big countries to actually go into lockdown. And we didn't lock down the entire country. It was Lagos, Abuja, and 3 other states. By 5 weeks, a lot of the information that was coming through was very clear that people were having difficulty even getting food, etc. And as I said earlier on in my talk, there are things that right now, if we were to come into that same situation, we probably would have done it very differently, because we know the effect that COVID has. But at the time, it wasn't very obvious. It's just like now, if we have Ebola, for instance, or just like we have the viral hemorrhagic fever in Ghana, if it comes into the country and it's reported in Kano, what do you think the authorities would do? They will sit down and say, let's wait and see who is affected more severely before we take action. No, I'm afraid when it comes to public health emergencies and management, it's better you take a decision and then review a decision afterwards than to sit down and say, let's wait and see. We do not have that luxury, I'm afraid. Thank you.
All right, thank you so much, Dr. Leo. Dr. Mukhtar, you want to weigh in?
Yes, thank you. Let me just add on maybe the question that was asked about confirming deaths. Certainly the numbers that have been reported, these are the numbers that have actually been confirmed. It is possible that that number is an underestimate, but the numbers that have been confirmed, actually the people died and they had COVID. We have to link all of that before they are classified as COVID-19 deaths. Secondly, we had a case in Kano in April 2000 where people were reporting high mortality. And that was the point when we mentioned there was a lot of apprehension. The healthcare workers were not sensitized properly. There was not enough infection prevention control in the facilities. A new lab that we set up in Kano, all of the workers in the lab came down with COVID infection because they didn't do the IPC properly. And that's why the issue of capacity building is very important. It's a continuous process. You cannot stop learning. You cannot stop improving. You have to do that. So in Kano, what we did that time, there was an investigation. We had a verbal autopsy and mortality review. A whole team was sent of epidemiologists to go and investigate that sudden death. They interviewed people in the graveyards. They observed number of people coming for funerals, reviewed the data from some of this and they wrote their report. They came to the conclusion. So there were a lot of things that were done, perhaps maybe were not highlighted. But again, as Dr. Sani mentioned, there are things that have happened which we could have done differently now, having the knowledge that we have today about COVID-19. And it's the same thing about any other public health emergency. When you are dealing with a disease that is previously not known, it is better to err on the side of caution and make sure that you prevent infection, you prevent deaths, you prevent mortality as much as you can. And I think the issue of lockdown, it's just in line with that. But later on, and the lockdown was not really long, and it was just in a few places. There are simulation exercises that are constantly being conducted, maybe in Nigeria and also in collaboration with other countries about these pathogens of unknown origin. And we always anticipate the worst. So whenever you have any new case, you anticipate that it's going to be the worst, and you take the prevention that you need to make sure that you contain the spread within the shortest possible time. Thank you very much, Rudolph.
Okay. All right. So who else? Dr. Nwosu, Professor Nwosu, do you have something to say? We're rounding up. We have to go to the next panel. Oh, go ahead.
Dr. Rudolph, before you go, I'm sorry, Dr. Nwosu, before you go ahead, Dr. Rudolph, there's a question with regards to, that would be for Dr. Mukhtar. There's regarding the J&J vaccine he mentioned. And the question was about the criteria for given this vaccines to, because he mentioned that this is the one that is more stable with regards to the logistics. And there is actually this issue with a side effect, a common side effect of thrombotic effects in risk factors, a thrombotic risk in females, actually males and females from 18 and above, and more in females from 30 to 49 years of age. So what do they do? Do they take into cognizance this side effect? Because this is fatal that one out of 7 cases results to death. So now that this is what is more available to the population in Nigeria, and look at the demographics involved, are they taking this into cognizance? And what are they doing?
The National Primary Healthcare Development Agency, which is responsible for driving the vaccines, has decided to prioritize the use of J&J vaccine for difficult to reach population. Because, as we earlier understood, that J&J needed just a single shot. Even though now there is some review about also having an additional booster dose. And people are trained about also reporting adverse drug events. And every day we also receive data from the mildest symptoms, to the severe symptoms that have been reported. I'm afraid over this last 6 months or 8 months, since J&J has been administered in the country, we have not recorded any mortality related, to other administration or adverse drug reaction, from the vaccine itself. So, but the important thing is set up the process, set up the system. For every drug, for every vaccine, we know that there are side effects, and we know that there are people who will not react normally. There is always that small proportion, that can have an untoward effect from the vaccine. So the important thing is setting up the system, make sure that the data is collected, and there is a quick response to that. I believe the NPHCD and the states are reporting on all of this on a daily basis. But so far, I'm not aware of any thromboembotic fatal effect on any of the people that received J&J in Nigeria.
All right, thank you so much, Professor Nwosu. You have.
Thank you again. Happy to come back. So again, I have 4 questions for Dr. Mohammed because, I have to really speak on behalf of the Nigerian people. My first question is, what happened to all those funds that were donated by Nigerians at the beginning of the pandemic? Then number 2, why is it that the health minister, Nigeria, does not visit the teaching hospitals to understand what's going on there and to see for himself the dereliction of facilities in these places? I know because some of us actually fund some of these teaching hospitals in one way or the other. And then number 3, do we have adequate funds to continue to fight COVID-19 pandemic and whatever else is coming down the pike in Nigeria? Thank you.
Okay, we are really out of time for this panel. I would like briefly for Dr. Liu and Dr. Mukhtar to respond. If Dr. Ndibe wants to say something, please let me know, and let's make sure that you are still with us and you're part of this conversation. Then after that, we have to go to the next panel. We are so much behind. Go ahead, Dr.
Okay, so yeah, let me just start. I think the questions are very straightforward, even though I got 3 out of the 4. What happened to the funds? The funds, as Dr. Aliu mentioned, were donated by the private sector. The fund was not spent by federal government, but the private sector provided a plan on how to utilize these resources. You are aware of the isolation centers they set up in the stadia in Lagos, in Kano, and 6 other states. You are aware of the procurement that they made of PPEs and other materials. You are aware of the oxygen supply that they also facilitated, in a lot of the hospitals. I'm not aware of this, what you mentioned, that Minister of Health not going to the teaching hospitals. I know last week I met him in a meeting with the CMDs of all the teaching hospitals. So, and I know that he was in Maiduguri to commission, and in Yobe also to commission one of the facilities there. So I think certainly that is not correct to say that. On whether we have adequate funds, yes, there is the goodwill. The system is there to mobilize resources, but certainly there is not enough funds. No one will say that we have all it takes, all the resources that you require to be able to face future pandemics. But the mechanisms that have been set in place now can be utilized to mobilize resources, not only just financial resources, but also human resource and technical resource that will be required. Thank you.
Okay, thank you so much.
So if I may just say something about the teaching hospitals, because I know Professor Ngosi is worried about the teaching hospitals, and it's a trend that is very similar to those of us that work in tertiary centers. The problem with the health system in Nigeria is actually not the teaching hospitals, it's the primary healthcare centers. The average primary healthcare center is not well resourced, and that's why people with malaria and other minor disease conditions go to the teaching hospitals and flood the teaching hospitals and overload them. The problem is not with the teaching hospitals. Secondly, the teaching hospitals, to be run properly, they need to be funded adequately. That resource really should go to the primary healthcare and the secondary healthcare centers first. And we make sure that we sort that out before going into specialist care. Thank you.
All right, thank you so much. Dr. Ndibe, are you still there? And do you have a comment?
Yeah.
Okay.
Yeah.
Okay, good.
Yes, I'm there.
Okay.
Just to reiterate what the 2 last speakers have said actually comes to confirm what I said during my presentation. The resources are up there, even though they are still not enough. But you find that down where most of those resources will come, which if they are properly funded, will actually place less pressure on the tertiary center. The resources are not there. Most of our PACs, people don't want to go there because they are poorly resourced, poor staffing, poor equipment, and so that makes, and the secondary health centers too. So it makes a lot of people move towards the tertiary centers, and then you find that even what the so-called lot of resources that you put there is still not enough for them to handle what. So we need to re-engineer the system in such a way that we send more resources to where the problems are, which are primary health centers and secondary health centers. In terms of resource use, in Nigeria, because of our antecedents, people always believe that resources are misused, and in some cases, yes, but I don't believe that all of it. A lot of things we actually provided during this pandemic from the private sector, from the federal government, and a lot of them came down to the states and to the PHC. So we are doing something, but definitely it's still a long haul to go. Thank you.
All right, thank you so much. I want to thank all our panelists for this part 1. I want to thank Dr. Liu. Thank you so much for joining us and being very kind with your time. And Dr. Mukhtar, thank you so much for joining us and being kind with your time and taking the questions. Also, Professor Nwosu, thank you so much for joining us. And Dr. Ndibe, I appreciate your time. We're now going to go to the second panel. Initially, I planned that we have a break, but we don't have time. I know that there are people who still have questions like Kayode and Michael Buefi, but I will please plead with you so that we go to part 2. There are people, some of our guests, they have to go, and we want to get them to participate, and then you can ask your question too. And of course, some of these our guests, the people that are in the panel, will stay by and stand by and also be able to answer your questions. So without wasting much time, let me introduce my co-host for the second part. And he is a physician and a research scientist in New York, Dr. Chisom Okezue. Chisom, welcome.
Hi, everyone. Good afternoon. I'm nice to be able to join this. I'm actually at work, but Rudolph wanted me to join, so I had to ask for a little bit of break. But it's always nice to be a part of conversations about Israeli healthcare in Nigeria. Can you all hear me?
Yeah, we can hear you. We can hear you. So we start this segment by getting somebody who survived COVID to tell his story for 5 minutes. Now, we had 3 people lined up, but we trimmed it down to 1 person because of time. So Austin Okwesile, welcome to the show.
Thank you, Rudolph, for having me. Can you hear me?
Yeah, we can hear you. Okay.
Well, I had a very terrible experience with COVID, and that was 2020, sometime around the middle of May. I started this weird sensation on my laps. It was very painful sensation. I didn't know what it was, and so I decided to go and see my doctor. I got to the doctor was able to figure it out, and he sent me for a CT scan. So I went for the CT scan. 3 days after the result came out, there was nothing. So I suggested to the doctor, that I would like to go and, take the COVID test. So I went there that very day and found out that I was positive. My God, that was, my world crashed that very day, because I was thinking, in my mind, how am I going to be able to isolate myself from my kids and my family? That was the initial thought I was having. I kept on asking the lady, am I going to make it? Am I going to survive this? The lady was like, she doesn't know what's going to happen. It's 50-50. So I went home. I told my wife, what's going on, that I was tested positive. Immediately we started the local therapy, the African therapy that everybody was doing. That is garlic, ginger, and inhalation of steam and stuff like that. And I think that was really what really helped me at the initial stage. So I was home for 14 days, and within these 14 days, a lot of strange experiences that I have never witnessed in my life, my entire life. My back was hurting, my temperature was like 104. I was sweating, very tired, couldn't get up from the bed. I kept on lying down, looking for a place to lie down. And thank God for the special grace of my wife, who, she kept on, trying to get me up, try to walk around and stuff like that, push me into the bathroom, try to provide, food. I wasn't able to eat anything because by this time I already lost the sense of taste and sense of smell. But I wasn't coughing. Strangely, I was not coughing. So after the 14 days, I was so happy. I was elated. I was like, okay, thank God, I survived this thing. I think if COVID is gonna kill you, it's gonna kill you within 14 days, because it was really bad for me, especially for the fact that I have some, underlying, conditions also. So I was like, okay, I survived this, thank God, I was so happy, so, but then after 3 days, that's on the 17th day, in the middle of the night, I wasn't able to breathe. Very scary. I mean, I was having pains on the lungs. If I tried to breathe, so this time, it's like I was having shortness of breath. I wasn't able to breathe at all. So I called my wife immediately. I said, hey, we gotta go, man. I'm having problem breathing. And, we jumped into the car, went to Bowie Health Center, and they did the CT scan. They were able to see the fibrosis on my lungs. So the doctor advised me that they're gonna take me to the COVID center. Initially, I objected. I said, no, I'm not going to any COVID center. I think it's better for my wife to take care of me at home instead of going to, any COVID center. Because when you look at the, on the television, you see what is going on. I mean, once they push you into the ICU and everybody is gone, I said, no, I'm not going to any COVID center. I said, I think I'll go home, just write the medications for me. So the doctor told me, hey, man, you have blood clots. So you don't have that chances. I mean, as a matter of fact, we are taking you right now to the COVID center. As we are speaking, the ambulance already came. I didn't have any option than to, jump into the ambulance because of that blood clot that, he had mentioned. So they took me to the COVID center at the Laurel Regional. And once we got there, they took me in and they said I should wave bye-bye to my wife. I'm like, wow, this is getting serious right now. So my wife left and they took me, started me on heparin. As at that time, there was no medication anyway. They started me on heparin and Tylenol and what again? I think I was dehydrated also, so we were giving me fluid also. So 3 days on my admission at the hospital, initially I wasn't coughing, but after 3 days at the hospital, I started coughing. I can cough for at least 1 minute without stopping, non-stopping, 1 minute. I mean, they provided the incentive spirometer. I was not even able to bring it up to 2. I kept on trying to blow it. The more you try to blow it, the more, I was coughing. So it was still stuck on that yellow stuff. I was like, damn, this is serious. How am I gonna come out of this? But the good thing is that luckily I was never intubated. I kept on telling myself, I can breathe, I can breathe, I can breathe. So I was not intubated. So on the 4th day, the doctor called and as we were speaking, there was nobody in the hospital. The doctors, they were already gone. You can only see the nurses around. The doctor called every morning on video and talk to you to know how you feel it. So I kept telling the doctor, I think it's better for me to go home because over here I'm not able to eat, and nobody cares if you are eating. Nobody comes to check on you. Everybody was gone. Once you are in there, they just come once in a while and peep. And I was not even connected to any monitor as at that point in time. So the doctor was telling me, oh no, you still have to be here. We are still monitoring you. I said, hey man, I'm not seeing anybody monitoring anything. Nobody's monitoring me. It's better for me to go home. My wife will take better care of me at home. So I kept on insisting, So the doctor said, okay, calm down. I told the doctor, look, I'm a healthcare worker also. He said, okay. Let's see what we're gonna do for you on Monday. So on Monday, I was discharged. So I went home. I kept on doing the local therapy that we are doing, the ginger, garlic, and the steam inhalation. And believe me, I think that was what really helped me. That was what really helped me. And by the special grace of God, I survived it. But then after 3 days again, when I went home after 3 days again, the same episode repeated itself again. I was not able to breathe again, you know. So I went back to the hospital again. At this point in time, the doctor said, hey, you know, I think actually the fibrosis is less than what it was in the beginning. I think this time around, you can, you know, go home and just manage the pain with pain medications. So finally, I was prescribed, I had the option to use Coumadin, warfarin, or Eliquis. But the only thing is that with Coumadin, you have to go for tests at every interval to check the therapy level. But I didn't use that, and I told them to give me Eliquis. The Eliquis is very expensive. For a month, it was costing me $500 because I had to pay out of pocket at this time. Luckily, I sought for insurance coverage, and so the government was giving us at that point in time. So they approved me for the insurance coverage. The hospital bill came, this is, and to the tune of $10,000.
Okay.
Within that week that I was there.
Aside of round up, this is a wonderful story, but I know we're out of time. Can you please we have other?
Sure. But the strange thing is, up to today, I'm still having the effect of COVID. I'm still having those pains. Once in a while, those pains comes. That's one strange thing about this thing. My life has not been the same since I had that experience. I'm still managing pains, but I thank God that I survived it. Thank you, Rudolph.
All right, thank you so much. I didn't inform people that Austin Okwesile is in America. We had two people who will have joined us from Nigeria who also suffered from COVID. Our goal is to compare, to see the difference in terms of how they are treated in Nigeria and how people who are patients here are treated. But we have to move on. I think by the time he talked about ambulance coming to pick him up, we basically know he's in America. All right, Dr. Chisom, you're next.
Yes, okay. So I'll go ahead and introduce Dr. Ngozi Obiwanne, who is a clinical research professional from Dallas, Texas. She will speak on medical research gaps and how to fill them for optimal healthcare delivery. Dr. Obiwanne, the floor is yours.
Okay, thank you, everyone. Yes, I actually would say I wish the government officials were still available because this is actually of a big concern to Nigeria. Now, when we talk about the medical research gaps in Nigeria, most of the questions that were being asked during the first phase was with regards to this issue. So I actually broke it down into different sections. So to make it put it in a very expedient manner. Number one, the issue we have is the human resources. So the way Nigeria is structured and the things we know that are going on in the country as we speak, and we are losing quite a bit of our medical professionals, and not just doctors, even our nurses. And now with the limited number we have, and we need to ask ourselves, those that actually trained to be, because not every doctor is experienced in research. So they're how prepared are our doctors and our nurses to actually, participate in research. Now we talk about issues concerning the general conditions. How do we capture our data? Data capture. How many hospitals can we attest to their data system, how they capture the data of every patient who is actually a potential subject in a clinical trial? Because it's when we start with conducting our own medical research, then we can actually come up with solutions that are in tune to our own demographics. Because like it or not, there was something Professor Musa said, is how are we, the immunogenicity of the medication, how are we testing in regards to our own population back home in Africa? Because whether we like it or not, something happened in Africa, something happened especially in Nigeria with regards to COVID. the effect that was expected was not what was seen. The rate of mortality rate that was expected was not what was seen. So the question is, what is that? What's that special factor? Have we tried to look into what is it? What it is? Is it our environment? Does it have anything to do with our diet? Or what is it? So these are questions we should ask. Well, how do we generate? How do we come to that point? We need data. But this is the limitations. This is part of the limitations we have, which when we talk about this, we're talking about the infrastructures that are not available. We talk about the institutions, how equipped they are, and how then we talk about that. Of course, the human resources are part of it. And we talk about our social cultural, the effect of our culture, the local, our traditions. We know that some of our people, like in the West, they believe in so much in the local herbs, the what we call abo and all that, the social organization, the religion, the politics. How does it affect us? These are things that bring forward the gaps in research. What are the religious aspects? How do people relate with new condition? Let's say there's a new pandemic now, monkeypox is coming. What are they thinking of? Where is their mind? Where their thought process? Where is it? So these are part of the gaps. This is another section that actually puts forward the gap we see in the medical research. Now we go down to logistics. Now, for logistics, we're looking at the local import and export policies. Now, for our importation policies, what do they look like? The cold chain shipment, how is it? I asked I wish Dr. Mukhtar was here, because my question was with regards to the vaccine that is received. How is it maintained? This is the cold chain. How is it transported to the rural areas? Now, how is it maintained at the rural areas? How are the temperature monitored? Is it viable? Finally, we ask people to take vaccines. So how do we know that what they're taking is viable? So these are questions. These are things that are issues, real issues that we cannot dance over. So we also have the institutions, the limitations with the institutions, and it still goes on to the general conditions with infrastructure, the illiteracy. Now go down to the educational barrier, the illiteracy. How do we pass this message to our people? How do they receive it? And how also do they, definitely we need feedback. How do we relate? How do we communicate with the people, mostly in the rural areas? When we have not covered, the rural areas, we did not say we are doing well in the healthcare sector, I must say. And so we have a lot of work to do. That's why sometimes I doubt the data that is coming out of, some of the publications. I kind of doubt it. And because I still ask the question, how do we relate with this? What's the data? Where's it coming from? Then the last point for me will be perception of cohesion or exploitation. How are the people? It still has to do with the literacy and the illiteracy and the illiteracy that's obtained in the society. How do they receive the message of vaccines? How are we educating the masses in the rural areas? I still insist, the rural areas. How do we communicate? How do we let them know what needs to be done and what should not be done? How do we, we talk about the hand washing teaching that was going on? How many of the rural centers were actually all the preventive process? How many of the rural centers benefited from all this? And we do not know. And also, we know that there are issues with in that we have some unique things in Nigeria where we have we've seen cases that we have fake vaccination cards, and people don't actually run the tests. So we ask ourselves the question: how do we checkmate all this? And how, for those vaccines that are being taken, how do we also, how do we research and know the efficacy amongst our people? Because we are actually different. Our demographics are different. How are we just just taking everything hook, line, and sinker from the West and putting it on our people. Like now, when the question in regards to J&J vaccine, and I know that Dr. Mukhtar mentioned that it was a small number. No, that from the recent FDA update, it is 1 in 100,000 doses administered. That does so that's 1 in 100,000 case for each of 100,000 doses administered. So that's quite a bit. So how are we checkmating all this? How are we screening for the risk factors, potential risk factors in this demographics? Because as we know, we have more of the young population. And since we're pushing the J&J vaccine to the rural areas, we have those populations more in the rural areas. So how are we checkmating to know that they are being, we are actually searching for the right stuff and also putting out the right message there and giving what is required? Because if we know that, okay, we look at the risk factors for thrombocytopenia, we know that, okay, this is applicable. Do we offer another vaccine in place of that? These were the questions I was expecting him to answer, but that weren't answered. So for us to have an optimal healthcare delivery in Nigeria, we need to address all this. And the fact is that it still boils down to governance. That is a fact, because we still need that conducive environment. We still need that conducive environment to make sure that we actually deliver an optimal healthcare system for the Nigerians and the Nigerian public. So that is what I think the government should actually focus on, because now once all this is put in place, it would also attract clinical research and opportunities in Nigeria. And here in the United States, there are still some studies. Some of the pharmaceuticals still have some global studies, and it's not just studies in the United States. You can be on a study as a global study. You have study sites, and they have sites in India and all in Asia, in the Pacific. They have in Europe, and even some Africa, like South Africa. Yes, but it's sometimes it says that the data coming out of Nigeria is questionable. So somehow it's not. It's conducting a research, of extensive of that extent. It's not really viable. They will question the data that's coming out from there. So, and also the subject safety. So our government should actually. I know that I wish everything was a bit diversified, where the government doesn't have a monopoly of a lot of things. Otherwise, I know the private sector will want to come in and individuals, but it still boils down to government. That's what I must say. And good governance, creating that enabling environment for actually the healthcare sector to thrive. And then the private sectors, because some of the sites, they are not owned by government, they're owned by individuals. So this is just what it is. And I must rest my case here. I will not go on. Thank you, everyone.
All right. Thank you, Dr. Mbazil Nwanne, for that rich presentation. I know that the government officials are not here currently, but we are going to keep this conversation going, and they are going to watch this, and we're going to keep in touch with them. But let me go to the next presenter. Ronsi Chidebe. Ronsi is the Executive Director of Project Pink Blue. He will speak on the role of the NGO in care delivery and awareness during a pandemic. Mr. Chidebe, welcome to the show.
Yeah, thank you very, very much. Thanks, Rudolph, for this great opportunity. I really appreciate it. I would start by saying that, coronavirus is here to teach us a lesson, actually. But I really thought that we learned in Nigeria, but I think it's still arguable. If you listen to all the speakers here, you'll definitely know it's still arguable. Nigerians' healthcare is still really unhealthy. That is the truth. But my only concern is that instead of fixing it, our rulers and our leaders are still busy flying up and down to benefit from other country's productive healthcare system. So this is really the painful reality. I mean, the Presidential Task Force or Presidential Steering Committee on COVID-19 did a fantastic work in controlling the pandemic at that time. However, the question has always been, are we sustaining this progress? All the epidemiologists that were trained and all the doctors that were trained, are they still in Nigeria? You know, so this is where the role of NGO is so important, and not just in our awareness, but also in advocacy. I remember during the COVID-19, one of the things that we did in my organization, Project Pink Blue, that we're focused in cancer awareness, is to release a very strong worded press statement urging the federal government to prioritize cancer patients in COVID-19 vaccination. Because we realized that most people who were really having access to these vaccines were, people who are very close to the high-end people. And let's not forget that the first patient of COVID-19 that died in Nigeria was a cancer patient. So as an NGO, we pulled that advocacy and said federal government must make conscious effort to protect cancer patients. And I think many other NGOs across the country did a fantastic and phenomenal work in creating awareness, reaching rural communities, in bringing all sort of intervention. Mental health in Nigeria is something that is rarely discussed. People are just more interested in giving people drugs. Sometimes people are just depressed. People are really anxious. People are feeling down, that they really need mental health support, but very little is being done in this regard. But I can tell you that during COVID-19 and even post-COVID-19, we saw many nonprofits really doing a lot of work in this area, which is really phenomenal. I just wanted to really sort of, bring this conversation to what we have learned from the perspective of the NGO, what needs to be done, trying to look from post-COVID and in preparation for another pandemic. We don't know when another COVID or another pandemic will come. So number one, I would say global health is truly not global. I really enjoyed, the questions from Professor Udo Kamosu, and I must really commend him. And, when you hear him speak, he's speaking, he represents the demographic that I belong to, right? And Prof, thanks for your presentation. I really enjoyed it. So my assertion now comes to the level of global health is truly not global. If you think about it, global leaders are more interested in what happens around them. Painfully, you see the Nigerian government leaders, more importantly, tilting to what really happens, what the global leaders say, instead of thinking of what the people say. Let's look at this from an example. Lassa fever was discovered in 1969 in a town known as Lassa in Borno State. Lassa fever, every single year, there is always one outbreak of Lassa fever, not just in Nigeria, in Ghana, Guinea, and in many parts of West Africa. Despite this outbreak, there is still no Lassa fever vaccine. Over 300,000 people are cases of Lassa fever is actually announced every year, and over 5,000 people die. So the question now is, COVID-19 came, and in less than 2 years, we have a vaccine for it. This particular Lassa fever has been killing a lot of people in West Africa for several years, and no one has gotten a vaccine for it. That is to tell you that the global leaders are interested in themselves. The pain or the anger is that the African leaders, the African government are not interested in protecting Africans. So they don't even listen to the healthcare of Africa. They are just more interested in where the world trade is. That is where they want to go. So this is one major thing we have to really, what we've really learned from COVID-19. I need to ask ourselves a very bold question on where is Africa going? Number two, sustain the achievement from the pandemic and strengthen the healthcare. The reality is that 60% of healthcare service, in this country is actually provided by private sector, and just 40 is probably by government. At the moment, there's no universal health coverage. 5% of Nigerians are only covered by health insurance. Interestingly, I saw in the comment section when someone was saying that there is a need to increase health budget. But I will shock you. A few days ago, I was speaking at an event hosted by the World Bank Farmer Access Foundation. We're talking about health financing dialogue. And the director of budget planning mentioned that the Ministry of Health returned some money from the previous year's budget. Who does that? And we all are here shouting that that the federal government, for instance, in 2020, the federal government budgeted less than 2,000 naira, that is 4.2 pounds for the healthcare of each Nigerian. And we have healthcare leaders that are returning money. So I think there is a need for us to really look at this problem of competence in healthcare. The people we have given our healthcare to manage does not have the capacity. So this is what we need to learn. This is one question we need to ask ourselves going forward, post-COVID. Increasing healthcare budget is great, but let's compare that with the competence of the people who are managing and people who can account for the existing budget. It is a shame, actually. It's really a big shame. I mean, it's still arguable who the current Minister of Health, Minister of State for Health, who he is, his experience in healthcare. The current Minister of State for Health, his experience in healthcare. I doubt if he's a doctor, a nurse, or probably a healthcare advocate. I doubt if he has ever done anything like that. So when you put the wrong people in a place where they don't have any experience in, what do you expect to get? So while we're thinking about post-COVID, we should think about some of the structural things that Professor Nwosu asked as a question, and I'm not sure he got the answers he needed. I also wanted to talk about the next thing I want us to think about is wrong perception of healthcare. And I'll tell you, because I am a health advocate in Nigeria here, the perception of the healthcare leaders and policymakers in Nigeria is that healthcare is an expenditure, it's like spending. While in other part of the world, healthcare is investment. When you budget for healthcare, you are investing, right? You see the kind of money they pump in all different sectors. But in healthcare, another thing we need to think about, health workforce. Our healthcare workforce is like really, really going low every single day. What are we doing? A previous minister mentioned that doctors should actually think about being farmers. And you also ask yourself, where are we picking these people from? Is there anything in Abuja that once you move from wherever you are, you get to Abuja, that your brain turned upside down, that you don't think properly anymore? Because these are professors that we looked up to. But once they get to that sphere of power, they begin to think as if like their brain were all wiped out. This is one serious issue we must really discuss. We must question ourselves, what do we want for the healthcare workforce of Nigeria? And believe me, if you bring all the whole best machine from all over the world to Nigeria without the workforce, it's zero. My next suggestion again will be, we need a law to restrict public servants from seeking healthcare abroad. That is it. We need to push this. In 2017 alone, President Muhammadu Buhari spent, 2017 alone, 103 days in London, receiving medical treatments, spending taxpayers' money, thousands of, pounds. In that same time, over 3,000 women died of breast cancer. Over 2,000 men died of prostate cancer, according to WHO, right? After the pandemic, we all assumed and thought that, things are going to change. But immediately the lockdown were all open, governors, himself, senators, and everyone are jumping to the US, to the UK, and all the rest of them. if we're not ready to have a conversation about medical tourism, especially among the public health, public servants, then we're really not ready to really move forward post-COVID, or we're not even prepared for any any other pandemic that is coming. My next suggestion again, or my next trigger again, is vaccine and volume. I mean, Dr. Aliyu, very brilliant presentation. He talked so much about vaccine uptake. But let's face the reality. Today, we're talking about vaccine availability in Nigeria. The problem is not availability. The core problem with vaccine is the volume of vaccine needed in Nigeria. I'll give you an instance. Over 50 million women and girls are at risk of human papillomavirus vaccine. So this over 50 million women need human papillomavirus vaccine in Nigeria to prevent cervical cancer and other sort of disease that the HPV could cause. But do you know that the 50 million doses that these women need in Nigeria can actually be sufficient for about 4 to 3 countries in Europe? Do you think Nigeria have the capacity to pay these pharma companies for them to forget about Europe that could pay the money and bring it down to Nigeria? And the government is not even thinking of how can we produce this vaccine in Nigeria. So these are the real issues in preparing for the next pandemic. Our volume, our population is explosive, is exploding every single day. And you can't manage this kind of population without building a sustainable healthcare. All we're talking about is vaccine uptake. The Nigerians are not taking up vaccine. You don't even have the system to even ensure that people can take this vaccine. People don't have, there's no system, that's the truth. All these things you hear about Nigerians take the vaccine, there is nobody educating Nigerians on what this vaccine should be. You need to educate people, you need to build a system that helps people to trust you. A healthcare system that is not trusted by the president. Who am I as a local citizen to trust that healthcare and take a vaccine from them? Well, I'll just put in very quickly some short suggestions. Number one is solutions, rather. Number one is check health corruption. We must check health corruption. We know it exists. Number two, e-government. Till today, do you know there are still so many federal government staff that are still at home because there are no laptop for them to work. So they were asked during COVID, go home. Till today, and they're still receiving salary. Why are we always not thinking about innovatively on how to get ourselves like an electronic country? Number three is Nigeria must begin to produce its own vaccine, as I said. Our healthcare leaders must begin to serve the people instead of their principals. That is all we'll see. People just come on Zoom meetings and come to meetings to defend their principles, to defend people who pay them and not to defend the people. Health budgeting should be seen as an investment and not just an expenditure. Fund PhD, that is the next solution. Fund PhD. We can't be talking about generating data in Africa and people in Nigeria have to struggle to pay for PhD. If you don't fund PhD, nobody's going to have the time to research. So until we begin to fund PhD, you will see young Nigerians who are smart that would write research that will match on the best journal, Lancet, name them.
Ramsey, can you please round up for us? Thank you.
Thank you very much. And my last solution is just to say, train doctors in research and not just in clinical care. Most of our doctors are wired to just do clinical care. And without research, we're just wasting our time. Clinical trial today is the multi-billion-dollar area, but we're not exploring it in Nigeria. Every medication they bring from Europe and US, we pump it into our people. No clinical trial is done. Thank you very much.
Yeah, thank you very much for that wonderful presentation and also giving us pointers on what should be done. Thank you so much. They say if a tree falls in a forest and nobody's around, does it make any sound? So our next panelist, Chiamaka Okafor, will give us a glimpse of the lessons reporters covering a pandemic learned and the struggles against conflicting narratives. Chiamaka Okafor is a senior reporter, diaspora and international community for the Premium Times. Chiamaka, the floor is yours. Is Chiamaka on and available?
Can you hear me?
Yes, please go ahead.
Good evening, everyone. My name is Chiamaka Okafor, and I work for Premium Times. So speaking on what the media or the media's role during the COVID-19 pandemic, so just two major things, on communication and then the knowledge gap for reporting the pandemic, as it was really new. And I mean, there was an existing knowledge gap in health reporting, or there is an existing knowledge gap in health reporting in Nigeria, but COVID made it quite obvious and glaring. But also to commend the media that a lot of reporters, my colleagues and I, rise to the occasion and did a lot of reading. So for instance, I have no science background, but I had to take a few courses so I could report and, communicate in languages people will understand. By people, I mean the average Nigerian out there. So there was that as well, but it wasn't quite widespread as the misinformation and disinformation that was out there. So it was really some knee-jerk reaction on how to counter this information. And then you needed to sit with experts, epidemiologists, virologists to understand what this means and how to translate it into simple terms for the Nigerian persons. That's a little I want to share on the knowledge gap, and also to say, unfortunately, the Nigerian government officials from the health sector are no longer on this call. Dr. Damages excused them after they had spoken and they left the call. This would have been important for them to listen to, because then in all of their trainings and capacity building, they meet key stakeholders that should be involved in their trainings and capacity building, which is the media, because the media doesn't know it all, right? And so we often will learn from the experiences or from the wealth of knowledge of other persons from different sectors. And so it's important that when such trainings are happening, media persons are involved. I'm hoping that Dr. Damages will relay these messages to them. I think that's important to do. Thank you for smiling at me. And then communication. So we saw a lot of stonewalling, which was a major challenge for me. I was in communication with Dr. Sani at the time, and also Mukhtar when he took over from Dr. Ali rather. But then you saw that information wasn't coming in real time. For instance, when the 1 million doses of vaccines expired in Nigeria, it took Reuters for Nigerians to know that that amount of vaccines were in the country and had expired. And now it also brings us back to the question of what value is attached to national media or local media, if you like. So I most times would like to say that the government of Nigeria does not respect or value media in Nigeria. And so they find it very easy and it's very comfortable to rush to the likes of BBC, CNN, Al Jazeera, Reuters to talk about things that are happening in Nigeria. But when we who are operating from Nigeria make us get information for the audience we serve, you get no response. And we got a lot of that during the COVID-19 pandemic, or in the wake of it, because of course it's still here with us. And for me, that's one of the reasons that contributed to, or that gave credence to a lot of misinformation or conspiracy theories that were flowing around, or flying around rather, during the time. But of course, there's just so much the media can do without information. We can't manufacture information. We need this information from authorities to, disseminate them. And when they don't come, we're really left with nothing to disseminate. And sometimes when you get expert opinions from the virologists or from the epidemiologists, and then you're trying to run it by the government officials, the people who take their words for it, to say, oh, is this really going on? And then they say this is not happening. For instance, again, when Omicron came into Nigeria, I was speaking with a virologist who told me this was in Nigeria already before the Nigerian government confirmed it or announced it. I wrote the story, but the Nigerian government said it wasn't true and came around, I think 1 week later or a few days after to say, oh, this is in Nigeria already. And it happened just about the same time. I was trying to confirm from them. So there's the stonewalling thing and also denying, events, things that are happening or things that were happening, and then turn around to say, oh, this is actually happening. And then it affects a lot the trust people have in government or what government has to say to them. And we see that a lot in Nigeria. The government of Nigeria has lost the trust the people should have for the government. And so when government says this, we're looking the other way, looking for alternative, responses or comments or instruction, and that shouldn't be what it is, right? Sorry, I'm seeing a few comments popping up, so it's a little distracting. Sorry. Yeah, so when people lose trust in government, it becomes very hard to manage situations such as what we saw during the COVID-19 pandemic. And how is this going to, or how has what happened during the COVID-19 pandemic prepared or is preparing us for the next pandemic, which is just around the corner? It probably will be the monkeypox or Lassa fever, which will go full blown very soon because management systems are really, really very poor. And then surveillance has improved in Nigeria. Yes, I'll give it to Nigeria, but it's still, a lot needs to be done. Yes, the expiration dates for the vaccines. So the question will be, why would Nigeria accept vaccines that are soon to expire? I don't have answers to that. Mukhtar would have been the best person to respond to that, but unfortunately, he left the call. On a platter. We should have options, yeah. We have options. Staying alive is one of it. And if people had taken the expired vaccines, we would have seen the same response that we saw during the polio incident with Pfizer. And then would have become more vaccine hesitant in Nigeria. So we wouldn't want to get to that point where we say no to vaccines or things that will help us stay alive, yeah? So I'm just going to leave that there to say that at every point, handling whatever national emergencies or national issues, the media is a key stakeholder, and every sector needs to realize that the media is a partner for democracy, for development, and for staying alive, literally. The media is a key partner. These are a few lessons we went through or we saw during the COVID-19 pandemic, and we're also seeing that a lot has not really been learned in terms of communications on the side of the government. Things come around really late, So I think I heard Dr. Ali mention, we waiting for things to see how bad things get before we, for instance, ask for a lockdown or start to address situation. And we're seeing that with the monkeypox as well. The cases of monkeypox are popping up in different states in Nigeria, but there's not been a national emergency approach, if I might use that term, to monkeypox or how to contain it before it becomes a real national emergency. Yeah, I'm sorry, a lot of the comments from this chat box are popping on my screen and they're quite distracting. But yeah, this is what we've learned. And even in the course of the job, some of us contracted COVID. I did contract in November 2020, and until sometime in June 2021, I wasn't feeling better, but yeah, that's it. Thank you very much for bringing me on.
Thank you, Chiamaka. Thank you so much for that contribution. And let me also say that I did not excuse anybody. People had other engagements, and I have to acknowledge that and accommodate them. I can force people to stay, So having said that, I said that we are going to have an opportunity to pass across some of this outcome of this conversation to all the officials. We have one last person before we take questions for the second panel and even the people who are still left from the first. We have my co-moderator, Dr. Chisom, to give us his take. He's a physician and research scientist here in New York. And he will talk about I forgot what we were going to talk about.
That's okay.
But you know what you're talking about.
Yes,
Yeah.
yes, yes.
Go ahead. Go ahead,
Yeah,
Dr.
I won't
Chisholm.
belabor. I won't belabor the points that have already been mentioned. I'm a physician here in New York, and I'm an internist physician, still in training, with hopes of specializing in critical care, ICU, in critical care, which is very important, obviously, in COVID. Dr. Damages wanted me to talk about the physician in pandemic times and the lessons for Nigeria, right? So I'm going to talk from my limited experience, and hopefully, I'm sure some of the other doctors on this panel probably have probably different experiences. I only have experience from what people told me in Nigeria, so I'm going to talk mostly about what I saw here in the US. So, quick points. Data collection is extremely important. It is extremely important. That is something that a lot of us here fostered and made sure that the government was doing. I wouldn't go into the politics of what happens in the US and how certain people of certain political leanings did not want data collection. But at the end of the day, because of how robust the healthcare system is and the level of scientific acumen that is here, a lot of the healthcare professionals prevailed over the politicians, and data collection continued. Because guess what? You can't address a problem unless you have data to support that it's happening, right? So you need to be collecting data, knowing who has COVID, how many test kits are available, what are the public health infrastructures and logistics that are in place, what is the current issue at hand? Is it that we have less vaccine, or is it that we have more and we have less ways of being able to disseminate them? For example, the vaccines that we got, from the information that I know, whether or not I'm not sure if it is if it has been verified at this point. What I know from looking at the news and some of the reports were that the vaccines were about to expire. There's nothing wrong in getting a vaccine that maybe is going to expire in 2 months or 3 months. Now, the key is when you accept that vaccine, do you have the logistics and the capability to be able to mobilize people and resources and get people vaccinated? Because guess what? If you allow those vaccines to be in the country and they all expire, and you haven't put out a message to tell people, oh, by the way, we got these vaccines, but we weren't able to mobilize and get it quickly into people's hands, therefore we're going to destroy them. What happens is when people find out later on, one, you've lost your credibility. People won't trust you anymore. So when you talk about vaccine, there's going to be incredible hesitancy. And so it kind of destroys the message that physicians are trying to get across. So data collection is important. Public health education is very, very important. As a child growing up in Eastern Nigeria, I remember getting vaccines in school, and there was a little bit of education. I know with the polio issue, I think Nigeria and Pakistan were, either Pakistan or Afghanistan were the two countries or 3 countries where there were still a little bit of polio left. To what extent Nigeria was able to mobilize the public health infrastructure and educate people, especially in northern part of the country, to combat vaccine hesitancy, I am not aware of. But it kind of tells us how important public health education is, because if we're able to educate people who may have, believe in different conspiracy theories, or who may have some cultural or religious mindset that may prevent them from getting vaccine, if we're able to do good public health education, we shouldn't have polio, still have polio in Nigeria at all. That's just an example that I'm trying to give. And the third thing is, I know that most of people, large percentage of people who are affected by COVID are those who are much older, the elderly, people who have comorbidities, so hypertension, high blood pressure, diabetes, and heart disease, and things of that sort. And I think where Nigeria may have escaped a little bit is that we have a larger, younger population who coincidentally tend to have less of those issues. And so if you have a country where you have a large percentage of the population are older, and being old, a lot of them already have these comorbidities, as we call them. It exposes them to being severely suffering severe consequences or disease when they get COVID. Now, it doesn't mean that because we cannot be transmitted to people who are younger. It just means that if someone who is younger has those, gets COVID or doesn't have those comorbidities, there's less of a disease state. But one thing I want to caution us about is non-communicable diseases like hypertension, diabetes are creeping up in what we used to call what we call third world countries. You know, in places like Nigeria, we're seeing high rates of hypertension in younger populations. We're seeing diabetes. So let us not feel that we are immune to a pandemic such as COVID, even though we may have escaped bearing the brunt of it compared to countries like the US that has a larger population of a larger older population. I want us to hold our public health folks accountable and our physicians accountable to make sure that we're looking into, you know, younger populations and making sure that diseases that we didn't used to see in younger folks are being well managed. You know, I can talk about, you know, instances of receiving text messages about, you know, of people who have passed away in Nigeria, younger people in their middle ages. And it's always an issue like if someone had a heart attack or someone's, you know, had diabetes, wasn't well managed. So there are comorbidities that we should address, which we know from studies causes you to have severe consequences when you have COVID. So 3 points: data collection, robust public health education, with messaging that is very clear and concise to make sure that our credibility is not lost, and making sure that comorbidities are addressed and there is good communication about, you know, the risk factors. Some of what I have seen being done by colleagues back home, I've seen people who have been doing health fairs, educating people about managing their blood pressure, doing blood pressure checks, and educating people about sugars, and, you know, making sure that people are eating well. One thing that I know is, even though we have a very high starchy diet in countries like Nigeria, there's a high level of physical activity. But as we transition from people moving from rural population, where people are more active and farming, to the urban centers where there's more sedentary life, all those comorbidities, you know, people are less active, it increases, and we're not eating foods from fast foods and things of that sort. So comorbidities are definitely important in terms of messaging by physicians, especially physicians who are in the primary care field and in the healthcare and in the public health field. I'll just stop it there.
All right. Thank you so much, Dr. Chisom. We are going to take questions now, and anybody who wants to ask a question, we raise your hand. I know, Kayode, you've been trying to ask a question. You go first.
Okay. Thank you so much. Good afternoon. Am I audible?
Yes, we can hear you.
Thank you so much. My name is Kayode Toriola. So I'm a banker and also a media personality here in Houston, Texas. I want to appreciate all the speakers and contributors to this seminar or public show. It has been quite rewarding and useful in our search for solutions to myriads of problems in Nigeria. Yeah, before I ask my question, I will make a little contribution. And I want to make reference to Professor Udoka's assertion. I mean, I want to thank Professor Nwosu Udoka for setting the record straight in terms of asking pertinent questions. Unfortunately, the Nigerian representatives, as far as this show is concerned, are no longer here. But just like I think the media or the Premium Times lady or somebody else said, Dr. Damages is here to relay our message to them, because we still want answers from them on some pertinent questions. You know, the problem we have as a country in our response to COVID-19 is just that we lack credibility, we lack data, we fail to use the resources that we have. I will not say we lack resources, because we have them, but we don't use them. And also, we expose our people to a lot of troubles because of our lack of seriousness in handling issues. Professor Nwosu has a question that why is it that the Minister of Health will not take it as a very important activity or responsibility to visit, I think, college hospitals? Nobody was able to answer that question the way I expected a serious person will answer that question. They only perambulated or paraphrased it. I remember Mukhtar answering that question, saying that he met Minister of Education and Minister of Health at a function recently. doing or holding meeting with some stakeholders. How has that one, how is it the same as visiting colleges of health to know what is happening on the ground, which will enable him to find lasting solutions to those problems of this COVID-19? It's very unfortunate. Another thing is that he also made reference to the fact that there was no data availability. And if you don't have data, how will you solve problem on ground? Because you need to know the number of people that are affected, even the numbers of people that are affected with this COVID-19, number of people that have been tested, number of people that have died. We don't have accurate data. So how will you now prevent recurrence of future problems? Now, as a banker, I now want to ask question about palliative. During COVID-19, and I believe Dr. Damages will note this down, I also send it to them. Though they are not here, they must answer some of these questions and let us know what they are doing, because we are also affected in one way or the other. The question is, the money voted for palliatives, if we all remember or we can recall, there was an instance that the rice or groundnut oil and some materials bought that were supposed to be distributed to people were, hoarded or were being taken over by some individuals. And it was found in an area around Abule Egba or Yanopaja last year. I believe some of us can still remember. What is the result, or what is the effect of that discovery? What did the government do to those people that did that thing? Because these are the issues. When people are having COVID, they cannot go to work. Are they not going to eat? Are they not going to pay rent? Are they not going to pay school fees? So these are the pertinent questions that I think these people still need to answer. And without wasting much time, I still want to thank all the participants here today for taking their time to attend this show, and equally appreciate Dr. Damages for all the great things you are doing. I know a lot of resources go into this. This is what the government is supposed to be doing, honestly. But because we are not focused, we are not proactive, and we are not thinking on how we can better the loss of our people. Our leaders are so selfish and inordinate, only just to please their pockets. That's why people are dying like chickens every day. All they are interested in now is 2023 elections. And just like Dr. Ngozi said, COVID is still much around, whether we like it or not. The earlier we realize it, the better. I was speaking with one colleague yesterday, and I learned that between April, this is a nurse who came to my office to transfer business in my office yesterday. He said COVID has started rising between end of April and now, astronomically. So the earlier Nigerian government realizes that, the better. We are only fortunate in Nigeria because of our environment, or maybe it is cultural. I don't know, that despite that the people are not even following all these COVID-19 protocols, there are still less or fewer deaths. We are just lucky, but we should not trivialize it or treat it with levity, because the consequences may be very, very detrimental. Thank you so much, and I appreciate the opportunity.
All right, thank you, Kaede. Thank you so much for that wonderful contribution. I don't know if anybody in any of the panels, Professor Nwosu, do you want to weigh in? I had your name mentioned several times.
Thank you, everyone. And I must say, I didn't know what to expect coming into this session, but I'm glad that I have learned a lot from people, so that's good. Yeah, the next question is, where do you go from here? In Nigeria, there is no continuity. Now we've done this one. Are you going to do something next? Are you going to get the health minister to come on your show? I know it will take a lot, but it's possible.
Yeah,
so he can answer our questions. I mean, we're not afraid of whoever. We will speak to power. We will speak for the youth. We will speak for our people, you know. So thank you for this.
All right, thank you. I want to say that on my own behalf, I will try to get Mukhtar to come back on the other show, maybe 90 Minutes Africa, and then that's more interactive. This was supposed to be just a conference, people speaking from different angles, but I can see that there are a lot of questions for the government side to answer. So I will
Can I
reach
make a
out
few
to him.
remarks?
Yeah, go ahead. Go ahead.
Yeah, just a few remarks because I have to get back to work. But I just wanted to, just as a public service announcement, because obviously people are gonna listen to the recording of this later on. I don't know how many people are watching this online. One thing I want us to, which is, this is kind of borders on public health messaging and how physicians communicate about COVID and vaccination to delay people. One thing I want to make point across is this: I'm going to make it very simple. When it comes to immunity, the way I see there are two types of immunity. There's one that you're making antibodies, right? The antibodies are there to prevent infection from getting into your cells and getting into your body, for lack of a better word. The second thing is optimizing your body so that if, for example, the infection crosses that protective barrier and gets into your system and you start having disease, that your body is able to recover quickly. What we found with vaccination, with this vaccine, and other healthcare professionals, please chime in and correct me if I make a mistake, is that even though its efficacy is not 100%, maybe it's 90%, 80%, for example, and you become sick, that optimization, which is the second part of the immune system, which is the T cells, that optimization has already been done with vaccination. And so even though you may become sick, you may not become very severely sick. So if, for example, you would have spent 10 or 12 days in the hospital, you spend 5 days in the hospital, or you don't even spend time in the hospital. If you are going to have shortness of breath or severe consequences, it may just feel like it's a regular flu, right? So it's important that we keep this message simple and put this message across to people so that even now that things may seem to be dying down, that people get vaccinated. The second point I wanted to make is the importance of data collection. Yes, that most of the early symptoms that we see and the main symptom is shortness of breath, but there are people who are having COVID symptoms that we are not used to. What we found out from research and from clinical guidance and some of the anecdotes is that COVID is a thrombotic disease as well. So when someone has COVID, there's increased risk of that person having clots, whether it's clots in the lungs, like one of the panelists who had COVID mentioned. And some people may be having other things happening. Someone may have a heart attack in their village, somewhere in the east or in the west, but you don't know that it was because of COVID because you didn't test that person. That person was COVID positive, didn't have any lung issues, but had clots, maybe clots in the leg or clots in the brain, right? Or had a gastrointestinal issues, which lead to maybe dehydration, electrolyte imbalance, and the person, became, confused and eventually passed away. So that's the importance of data collection. So that when people are sick, they get tested for COVID. So we can be able to correlate, okay, is this because of COVID or is this maybe some other independent issue, right? And in terms of monkeypox, I think the lessons of COVID should tell us that we should start putting things in place, right? Here I am in New York. Our monkeypox cases weren't even that much as of 2 weeks ago, but we're already taking precautions. I've treated at least one monkeypox patient, and we were very, very careful in how we handled the patient. Even when we didn't have enough data in terms of transmissibility and how infectious it is, we were extremely careful in how we operated. Data were being reported. People who were exposed were being notified, and things of that sort. And that's something that's missing in Nigeria. So you have to have contingencies in place so that you don't wait for you to have a huge pandemic and you are struggling trying to find ways to handle it, right? So that's all I wanted to say.
All right, thank you. Dr. Gwane.
Hi, everyone. I must say that I really enjoyed this forum. I wasn't really expecting to enjoy it this much, but I did. So, and I must reiterate, we need to get the government officials here. We need to speak to them. They need to, because this is actually the bulk of this rests on their table. We can talk from today to tomorrow of what we experience here, but the truth is we are actually trying to channel something positive to the people in Nigeria who are actually not they're not getting the best out of whatever is available. So now we're talking about the data collection. We know definitely that we do not have enough data. We don't even, what do we have in place? How do we generate our data? Can we even account for the deaths and births in Nigeria? Let's start from the basic. Can we account for that? Let's start from there. Maybe that's the first start. Then we can come up the ladder. Now, vaccines, we want to encourage them to talk to people about taking vaccines. How about people get out there and get vaccinated and they're worse off for it because they didn't know that they didn't get a viable vaccine. So what is our culture? What the culture change system? What is it like in Nigeria? We know about the light issues, the NEPA in quote. So how are these vaccines being stored? Let's start from storage before we talk about dissemination. Even the test kits that are available, they still have expiration dates. How do we know that people are being tested with kits that are viable? So what data are they giving us? They have paper, and what data are they giving us? Where did they bring all that from? Publications here, from what? So that's where I'm coming from. We need to get to the grassroots and we need to tell ourselves the truth. They are not being totally honest. There's a lot of things amiss. And when we get all these things in place, now we can comfortably start researching. We have a lot of bright minds in Nigeria. Now we can now create our own. Now somebody was talking about Lassa fever being in. Yes, when I was in teaching in National Hospital Abuja, yes, I saw cases of Lassa fever. I know what it was like, and we know how the healthcare professional. Oh my God, a nurse had Lassa fever. Nobody wanted to pass her medication. That's the nurse that works in National Hospital. Nobody does this. They are all being careful. Cholera has killed medical practitioners in Nigeria. Just cholera. So what are we doing in our country? That is just the truth. We need to go down to the grassroots. And the honest truth is that the government, there's monopoly of the healthcare sector and for everything. So we can't really do much without going to them. So we still have to come back to them and say, hey, can you please make the level the playing field so that people can come out? There are people outside the country who would want to chime in, who want to bring a lot of things down to Nigeria to help the average Nigerian. But no, and I still want Dr. Damages. Dr. Mukhtar still has to answer that question regarding the J&J vaccine, because they need to tell us how they are screening the people, how they are actually screening the people to prevent this. Because the truth is that the side effects are there. So there are people like here, you can say, you want to recommend this to a patient, and you say, oh, the risk factors. You have the risk factors that are applicable for thrombocytopenia. So you're not a good candidate for J&J. So why don't you go ahead and get Moderna, or go ahead and get Pfizer. Now for the Moderna, we've known that there's this cardiovascular involvement. So we see that this is the case. We say, okay, why don't we go ahead and get Pfizer? So why are we pushing down J&J? And we're not even trying to know who is a risk of this event. And we are trying to, he said it's small. No, it is not small. 1 in 100,000 is not small. So when he used that word small, I was like, okay. I thought he would stay around for a bit so that he will understand the statistics and the data, the numbers. The 1 in 100,000, it's not small. So rounding up, we definitely need a region, and we need to have them on board, and they need to answer the serious questions.
All right.
Thank you, everyone.
Thank you so much. Is there any other person who has a question or comment?
I have one last point.
Okay, go ahead.
Because I was seeing a lot of comments in the chat, and I don't want to belabor the point of a vaccination and the science of it, but the mistake that people make is people think, okay, so let me give you an example. If there's a difference between 70% or 80% of Nigeria being vaccinated within 1 month versus you achieving that 70, 80% in 1 year. And the important thing to take note of here is considering that the vaccine are not 100% efficacious, and also that the vaccine, the immunity that the vaccine confers starts to diminish at some point. So therefore, when you look at a snapshot of the first day that you start vaccination to a year after, yes, you may have 70% on the books, but at that current point of that 1 year mark, how many people's vaccination immunity are still active? So even though you may have 70% vaccinated, it may only be about 20% whose vaccination are still effective. And so when you're looking at herd immunity, right, and you want to achieve herd immunity of about 70, 80%, you actually have not achieved herd immunity. On the books, you have 70% vaccinated, but in reality, you only have about 30%, and you still have not reached herd immunity. And so the issue that people see in countries that have high vaccination, and you're asking, oh, this country has a high vaccination, but why don't they have increased immunity and less COVID cases compared to places that don't have a vaccination? You have to consider this perspective as well. For example, in the US, if many people were vaccinated within the first 2-3 months, and we achieved that very high percentage, we would have achieved herd immunity and had less cases. But the issue was people kept having, there were a lot of issues with messaging, logistics about putting things in place to get the vaccine to everybody. And so you can't really make that argument of, oh, this country has a high vaccination rate, therefore they should have less cases. That's my last point.
All right, thank you so much. Any other person, any other comments?
One last comment. The reporter, I don't know why she's still around, but she said something about the government not listening to them. If she can actually write a piece on those questions that the government officials were not able to address, I think they will listen to her.
That's a good point. And I believe that there are other reporters who are watching and who will write stories based on the conversations that we have today. On that note, I want to thank everybody that joined us today. I want to thank Dr. Sani Aliu, Dr. Mukhtar Mohammed, Professor Benjamin Mosu, Dr. John Ndibe, Dr. Ngozi Obiwane, Dr. Chisom Okezue, Mr. Ronsi Chidebe, Chiamako Okafor, Austin Okwesile, Stella and Chooks, and Humble Prince. I thank you all. I want to also thank Paul Adeyeye, my project manager at the Open Society Initiative for West Africa, for his support and patience with me. And of course, all those in the organization who gave this opportunity to me. I also want to thank those behind the scene who helped to make this possible. My advisors, Chido Onuma, Oken Dibe, my technical people, Ola and Professor Ajibola. And I take responsibility for what didn't go well as planned. It was perfect on paper. Seriously, it was very perfect on paper. It didn't start well, but thank you all for spending the time with me and your evening on Saturday. I promise you that in days to come, we are going to locate the government officials and we are going to get them to answer more questions as you guys have demanded. On behalf of everybody, once again, thank you and hope to see you next time I call on you. Really, I appreciate it. It's not everybody that you call and they will help you, especially African Queen, Dr. Obiwane. I really appreciate you stepping up and helping me a lot. And of course, my Dr. Dominic. Thank you so much, everybody. And hopefully we will do this again in no distant time. We do this and get the government officials to answer the questions that everybody is interested in. Okay, and on that basis, I say thank you and see you next time.
Rudolph, did you end the broadcast?
Yeah, I did. Okay. Oh, no, we're not ended. This one will play, then we end.
Okay.
Yeah.
There's no sound though.
No sound?
Yes.
You can't hear anything? No?
African Queen, can you hear anything?
No,
I'm hearing it here. No? Nobody's hearing anything?
Yes.
Oh, all right. I'm so sorry. This is what happened. I had a lot of videos to play, but today was just bad. It didn't go through. All right. Thank you, guys. I'll see you next time.
All right. Thank you.
Okay.